Which month are you planning?
It is on
We are
29
live, sir.
October.
We are
Request
live.
everybody to keep mute. Very good evening from Ortho TV. Today we have Delhi Orthopaedic Association's Orthopaedic Implant Specimens webinar. Now I request Manisha to start the webinar.
Yeah, good evening, everyone. I'll just share my screen. Oh, sorry. My screen is visible?
Yeah, sir. Go ahead, sir.
Yes.
Just put it on slide mode.
Yeah,
Yeah.
1
Go
minute.
ahead.
Yeah, and good evening, everyone, and welcome to DOA PG teaching webinar. Now we have a very special series of table viva, means orthopedic specimen and implant. There are two important table viva sections. So we'll be speaking on that. It's a unique webinar. And Delhi Orthopedic Association welcomes you all. And the IOA president theme is, it matches with the IOA president theme, excellence and perfection in orthopedic education and patient care, and achievable vision. And our DOA president theme, Dr. Sharad Agarwal's theme, is way, evidence, and respect experience. So I welcome you all.
म्यूट हो गया मनीष अनम्यूट करो
Dr. Manish, you are muted.
Now it's okay?
Yeah, you're okay.
Yeah.
Unmuted. So
Yeah.
put it on slide mode and start with initial.
Yeah.
Yeah,
So
start.
I'm Dr. Manish Dhawan, and I'm webinar moderator, and I was treasurer of Indian Orthopedic Association for 6 years till August 2020, and I'm also president of Asami India. I work in Gangaram Hospital as a senior consultant and professor at Gripmer for National Board, and my special interests are complex trauma, limb lengthening, and deformity correction. I welcome Dr. Sharad Agarwal, President of Delhi Orthopaedic Association. He is Senior Consultant Orthopedics and Joint Replacement Surgeon at Max Super Speciality Hospital, Palpadganj. He is past President of East Delhi Orthopaedic Association. He has presented academic papers at various national and international conferences, delivered guest lectures at various national and international conferences. I welcome you, sir. Dr. Hitesh Lal is Secretary of Delhi Orthopaedic Association, and he is professor at Sports Injury Center, Safdarjung Hospital, and he is former professor at RML Hospital and at Central Institute of Orthopedics, Safdarjung Hospital. He has more than 100 national and international publications to his credit. He has delivered guest lectures at various national and international platforms. So I welcome Dr. Dr. Hitesh. Probably, I think he will be joining soon. Dr. Ravi Chauhan is webinar coordinator, and the concept and designing of each webinar along with technical assistance is given by him. His role is very important. He's kind of a backbone for this webinar. He works as a trauma and pediatric orthopedic surgeon at Sir Gangaram Hospital, New Delhi. And he's also EC member of Asami India. Dr. Ashok Sham is editor of Ortho TV, and he's assistant professor at Sancheti Institute of Orthopedics and Rehabilitation, Pune. He is chief researcher and head of IORG and editor of JOCR. He is the member of Basic Research Committee of IOA and EC member of Bihar Orthopedic Association. I welcome you, Dr. Ashok. Dr. Neeraj Bijlani is coordinator of Ortho TV, and he is a consultant orthopedic surgeon and tech enthusiast at Ortho Tech Clinic, Mumbai. I welcome you, sir. Dr. Shamsul Huda is a dynamic member of our team, and he is coordinator of Ortho TV. He is consultant orthopedic surgeon at Rajeshwar Hospital, Patna. He is also joint secretary of Bihar Orthopedic Association, Asami, and editor of Ortho World. I welcome you, Dr. Shamsul. Shamsul has a very important role because he has a whole technical control with him. Now, coming to expert panel, we have a very good expert and highly academic expert panel. And one of the panelists is Professor Lalit Mani. Everyone knows about him. He is editor of Indian Journal of Orthopedics, and he is president-elect of Delhi Orthopedic Association. He is director professor at Maulana Azad Medical College and executive editor of JCOT. He has authored many books and also chapters, and has numerous national and international publications to his credit. He has chaired numerous sessions at various state and national conferences, delivered numerous lectures at state, national, and international conferences. I welcome you, Professor Mani. Or so next panelist is Professor Sandeep Kumar. He is Joint Secretary of Indian Orthopaedic Association, and now at present he is the acting Secretary of IOA. He is Professor and Unit Head of Department of Orthopedics, Hamdard Institute of Medical Sciences and Research, New Delhi. He has authored books in several chapters, and he has been awarded Rula Best Research Award for the year 2019, and he has many publications to his credit. I welcome you, Dr. Sandeep. Dr. Anup Agarwal is Secretary of UP Orthopaedic Association. He is Vice President of Asia Pacific Trauma Society, National Delegate at Asia Pacific Orthopaedic Association, Council Member of Asia Pacific Orthopaedic Association. He has been faculty to many international conferences, and like Turkish Orthopaedic Association, Malaysian Orthopaedic Association, Egypt Orthopaedic Association, and all national conferences. And he is the reviewer of Acta Orthopedia et Traumatologica Tunisia. I welcome you, Dr. Anup Agarwal. Dr. Harimom Agarwal is a known face in teaching, and he is Secretary of Punjab Chapter of Indian Orthopaedic Association. He is Associate Professor at Government Medical College, Patiala, Punjab, delivered numerous lectures and at various prestigious platforms. He has chaired various sessions. I welcome you, sir. So with this, I thank you all, and I now call Dr. Sharad Agarwal, President of Delhi Orthopaedic Association, to please giving opening remarks.
Thank you, Dr. Manish. Good evening, friends. I welcome you all to the postgraduate teaching program of Delhi Orthopaedic Association. Today's topics, specimens and implants, are unusual but important not only for examination point of view for the postgraduates, but also to understand basis of orthopedic illnesses and their management. We have a learned faculty of senior teachers to speak on the subjects and equally experienced members to discuss them. I welcome the whole esteemed faculty who are sparing their valuable time to grace the webinar today and sharing their thoughts on these topics. I'm sure not only the postgraduates, the webinar shall be an update for all of us. I welcome the whole DOA faculty and all delegates who are participating in today's webinar. My thanks to Dr. Hitesh Lal, the convener of this webinar, Dr. Manish Dhawan, who is moderating it. Special thanks to Dr. Ravi Chauhan for his untiring efforts in organizing the webinar. And thanks to Dr. Shamsul Huda, Dr. Neeraj Bijlani, and Dr. Ashok Sham for the technical support. Thank you.
Thank you, Dr. Sharad. And I now request Professor Lalit Mani to please introduce the faculty.
Thanks, Manish. Thanks, Dr. Sharad Agarwal. Today we have a very dynamic faculty. We have two speakers, Dr. Sumit Arora and Dr. Amit Sharma. Both of them are very popular teachers in their own institutes. Sumit Arora has worked both in MAMC and in Safdarjung, and right now he is an associate professor in Maulana Azad Medical College. A topper throughout his life. I don't think he stood ever second, and an amazing feat that he has to his name is that he has publications almost in all possible orthopedic journals, which include JVGS American and Clinical Orthopedics and JVGS British and whatever you can sort of think of. He's a very popular teacher in MAMC as well as in VMMC, and he has a big student following. And I thank Sumit for accepting this invite. And he's been a student as well as a teacher to this topic in our popular MAMC PG course in the last 2 decades. The other speaker is Dr. Amit Sharma, again a very popular teacher. He's worked both in MAMC and in Lady Hardinge Medical College, and right now he's an assistant professor in Lady Hardinge Medical College. Again, he has a big student following. He's a vociferous speaker, and he has abundant amount of knowledge. That is why his lecture is going to be longer than what is expected. Again, he is very much into academics, and at his young age, he has more publications than many others in orthopedics. He's one of the pioneers in 3D printing. He was the first person in the country who had a thesis in 3D printing. So we welcome both the speakers, Dr. Sumit Arora and Dr. Amit Sharma. And without further delay, I think Sumit can start and share his screen.
Thank you, Dr. Lalit. And this whole program now onwards, the convener will be Professor Lalit Mani and Dr. Sandeep. They are panelists also. So please share your screen now.
Yeah. Is it visible, sir?
Yeah, it's
Please go
visible.
ahead, sir.
Just put it on the play mode, full screen.
Yeah, go ahead, sir.
So, good evening, everybody. I am Dr. Sumit Arora. Thank you, Dr. Mani, for giving uh, such a elaborate introduction. I will be speaking about pathology specimen in orthopedics. So many students often feel that they are not having good backup as far as these topics are concerned in the ward round, especially in DNB orthopedic examination. So I will briefly cover the pathology specimen, especially pertaining to the DNB orthopedic examination. I would like to thank Dr. Dhananjay Sabat, who is faculty in orthopedics in Maulana Azad Medical College, and Dr. Meeta Singh, who is faculty of pathology in Maulana Azad Medical College. So first of all, the student should start with the description part of the specimen, whatever is being shown to him. So the section number 1, identify the part. So before you identify the part, you will have to speak in terms of whether it is a mounted specimen dipped in preservative, or it is a gross specimen that has been photographed and has been presented to the student for the exam, right? So if the mounted specimen part is there, so one should start that it is a mounted specimen in preservative, which appears to be. Now we'll come to the next part. We'll have to identify the bone, like it is a part of the femur. So you have to identify whether it is a proximal femur or the distal femur, or it may be the specimen may belong to a joint or maybe of whole spine. So you need to identify the correct anatomical location. Then comes the location within the bone, whether this is especially important, especially for the tumor part, whether it is epiphyseal in location, metaphyseal, or diaphyseal in location. Next comment is pertinent, whether the physis is visible or not, to get to know the skeletal maturity, as there are few tumors which are common in skeletally mature and others are in skeletally immature. So one should speak out differential diagnosis accordingly, and one has to be very pertinent about the presence of or absence of physis in the specimen, because the further viva may divert in altogether a different direction. And the last part is whether it is a whole specimen or it has been cut open. So this is also very important, and at times the student got confused that it is looking like a two-part of the specimen. It is actually not a two-part; it is a cut-open sort of specimen, and it should the student should describe the description in the deeper layer also. So one has to start the description on considering these points. One has to start with it is a mounted specimen dipped in the preservative, which appears to be a proximal femur, and the location appears to be a metaphyseal, right? The physis appears fused, and it appears to be a cut open specimen of the proximal femur. Now you have to further qualify the lesion, whatever you are seeing there. And the next part of the description is describe the abnormality that you are seeing. First is the nature, whether it is a solid looking tumor, or it is a soft friable, or it is a cystic or a variegated appearance. Next comes the location, whether it is centric or eccentric. Eccentric may be a peripheral one. There are few where you will have to qualify for the terms of periosteal and parosteal, right? In parosteal, you see a cleavage between the bone and the mass clearly, and periosteal will be originating directly from the periosteum. Then you may comment on the matrix, if it is visible, bony, cartilaginous, or fibrous. Cartilaginous matrix, to be precise, appears as a silvery sort of shiny, fluffy mass that you may describe it as. The secondary changes may be there, which may suggest the student whether it is we are dealing with a benign pathology or the malignant one, which will constitute central necrosis or the secondary hemorrhage or the secondary cystic changes. Then important description comes about the cortical destruction, whether the cortical is destroyed on both the sides, on one side eccentrically or not, whether there is elevation of the periosteum is apparent, intramedullary spread, you may comment upon. Tumor margin or capsule, if it is visible there, it is well defined or ill defined, and extension into the soft tissue or the joint, or the invasion or infiltration into the surrounding tissues. So I am just sharing an example how the students should proceed in their table viva. So this one may think of the cortical normal cortex of the distal femur, and this appears to be a medulla. There may be a doubtful invasion by the tumor cells, but majority of the time, because of the fixation of the tissue, it may appears in normal cases also. So here there are definite area of pathology is this, where abundant soft tissue mass is reaching beyond the bone, and the cortices are thin, as one can see. Obvious thinning of the cortices, destruction of the cortices, and the extension into the soft tissues. The node may be made up of this peripheral side secondary hemorrhage, and there is central necrosis that one is observing here, right? This is obviously a distal femur cartilage and the knee cartilage, and this cartilage is acting as a barrier to the spread of the tumor towards the joint. This one may, if one is able to see or may be able to pick up, it will be very great that the tumor cell is seeing within the blood vessels, vein. So this these all things will go in the favor of the pathology being in the malignant one, right? So one by one, I will describe the classical things, and at the end, the student must commit some sort of provisional diagnosis, right? And since seeing the gross specimen only, one can only give a provisional diagnosis and possibly differential diagnosis. Obviously, the final diagnosis of majority of these cases are based on histopathological examination, not by gross examination. So I am narrating few of the common slides or common specimens that you are expected to see in your exams, and you should be attentive towards the description of each one of them. And giant cell tumor, it will be the one of the common specimen that you are expected to get in your exam. A common age of presentation and the location and the common sites of its origin, it's all theory, and you must be aware of all these things. Coming on to gross pathology, so if you have to describe this specimen, so you should start with that it is a cut open distal femur, and it has been photographed, and the photo is being shown, and the lesion looks like that it is an eccentrically placed metaphysio-epiphyseal location of the distal femur where the physis has been fused, and there is a central cystic changes and the central area of necrosis. It is more towards the lateral side, and there is no apart from this small, there is no obvious periosteal elevation that one can see. And then the central and the periphery part is looking cystic degeneration and the necrosis with blood filled cavities. So I have put few slides also. They may not be very pertinent because in majority of the centers of DNB exam, you are not likely to get the slides, though there are few centers which are still asking for the student to identify what is there in the slide. So besides that situation, these things are likely to be asked in your theory exams, or maybe asked theoretically in your Viva part, that what all are things that you are likely to see in the histopathology. So the typical thing you will find there will be the osteoclast type of joint cell, right? So there are other types of appearance also I will shortly cover. Then the next Viva that you may be asked about the what all are the giant cell variants. So first of all, you should be aware of its definition, that it includes the tumor which shows giant cell in the histology. So it is a easy method to remember the giant cell variants A, B, C, D, E, F, G, H. A for ABC, B for brown tumor of parathyroid, or C for chondromyxoid fibroma and chondroblastoma, D for desmoplastic fibroma, E stands for epulis, also known as giant cell liberated granuloma, F stands for fibrodysplasia and non-ossifying fibroma, G stands for giant cell rich osteosarcoma, and H stands for benign fibrous histiocytoma. So there are few physiological giant cells, they are present in the form of the megakaryocytes, and there are few which are pathological. So one need to identify, and it may be asked in, as I have said, that in your Viva also or in a theory, Langhans type of giant cell are typically seen in tuberculosis, but may also seen in sarcoidosis and histoplasmosis. And it is a horseshoe shaped multiple epithelioid cells that are seen in the periphery, right? There are now next the foreign body giant cell or a show-off and redisturbance. They are not very particular, and you are not likely to get all these things in your slides in the exam, right? Next common thing that you are expected to know is the osteosarcoma. As from the theory, you know that it has the bimodal distribution, and the 75% of the cases occur around the knee. There are several subtypes. By the location, it may be a central or juxtacortical. Multicentricity may be there. Degree of differentiation may be there. Like there are few parosteal osteosarcoma. They are well differentiated, and it can be in some cases is highly malignant that are dedifferentiated tumors. Histological variants like osteoblastic, chondroblastic, fibroblastic, small cell, and telangiectatic type. These are the highly malignant tumors that one can see. They are associated with retinoblastoma, Lee from Annie, and the Rothman-Thompson's syndrome, as you are aware from your theory part. So coming to the basic thing that we want to discuss here, first of all, this is the photographed cut open section of the distal femur, where the patient appears to be nearing the physial maturity or skeletal maturity, as the remnant of the physis is just visible. It is not a proper physis. It is about to fuse. So the patient's age must be around 16 to 18 years, right? So predominantly, the mass appears to be in the metaphysis of the distal femur, and it is a 10 white solid tumor cell fills most of the medullary cavity of the metaphysis and the sorry for the typo, it is a distal diaphysis, and it is expanding and infiltrating through the cortex. One can see this is the normal cortex, and here the cortices are the thinned out and destroyed, and it has lifted off the periosteum, and it has formed the Codman triangle sort of appearance, both anteriorly as well as posteriorly. So these are highly pathognomic features of osteogenic sarcoma, and area of hemorrhage and central necrosis are seen. As I have said that one can see the infiltration of the tumor within the vessel layer. These are the other varieties one can see, right? Here it is a typical posterior distal femur that are being oriented is a periosteal or parosteal may be present, and it is the specimen of the proximal humerus where the Codman sort of appearance is there, though the Codman triangle appearance is classically described in radiology, but its extrapolation on the specimen is clearly seen here. And in proximal telangiectatic variety is quite common in proximal humerus, right? And coming on to histopathology, though you are not likely to be asked these in your DNB exam, but one must be aware of abundant pink homogeneous osteoid. So this is osteoid. These all are the osteoid material that are present in abundance. So this, since it is a bone forming tumor, so the abundant pink homogeneous osteoid is the pathognomic feature of osteogenic sarcoma. Next common thing that you may be asked about is the chondrosarcoma specimen. It may be a primary or the secondary one. In enchondromatosis, Olier's 50% and the Mafusis, almost all the cases. And diaphyseal eclasis in 20% of the cases, and osteochondroma 0.25% of the cases are likely to go under chondrosarcoma transformation. And the common sites are pelvis and femur, right? And it is one of the most common malignant tumors of the hand. So coming on to the gross pathology specimen, it will be majority of the time will be a bulky one and will be made up of lobules of gray white. So you can see a big lobule here, right? of somewhat translucent or glistening tissue. This gelatinous appearance is quite pathognomic, and calcification may be present. One can see that the cortex here is relatively normal, but as you go there, and it becomes more and more eroded. So you may skip this part. One may find the abundance of cartilaginous matrix in that. The next common tumor that you may be asked in the exam will be the Ewing sarcoma. It is majority of the time you will find the location is in the diaphysis of the long bones and may be present in pelvis, rib and scapula, at times spine also. White and gray mass like brain-like tissue will be there, and it may be a hemorrhagic tissue also. There may be a central area of you can see hemorrhage here, and these are the necrotic parts. Invasion into soft tissue is quite apparent. This is a common thing that one must be aware of, that there are several de-differentiated small round cell blue-like cells will be seen in abundance. So these are quite pathognomic of Ewing sarcoma. These are PAS positive. At times they form one can see here in the 7 to 8 tumor cells arranged in a circle. It is known as Homer right pseudo rosette formation. So in the theory part or in the Viva, you may be asked about the small differential diagnosis of these small round cells tumor. Apart from Ewing sarcoma, one must say that these type of pathological appearance may also be seen in PNET tumors, in reticulum cell sarcoma, non-Hodgkin lymphoma, small cell carcinoma, mesenchymal chondrosarcoma, and the neuroblastoma. There are few leukemias also that may present like this. So these were the grossly malignant tumor that you are expected to see or maybe asked in your exams. There are few benign tissues also that you may be asked in your exam. The most common one will be osteochondroma. And if you go by the gross pathology, it is the whole specimen of the resected part of the osteochondroma, which appears to be sessile. And you can see the cartilaginous gap here. At times, one may find a bit of peduncle also. If the clear-cut peduncle evidence is there, you can say is pedunculated also. This cartilaginous cap is usually regular and the thin. So whether it is thick or not, ideally one should be having a cut open section of these things to comment upon the thickness of the cartilaginous cap. So it is a common pathology seen in diaphyseal eclasis where there are multiple or there, and on the epiphyseal side it can also be seen in rare situations, and it will be termed as Trevor's disease in these circumstances. Next common slide that specimen that you may be shown is the chronic osteomyelitis. So before describing it, one must be able to differentiate between the three things: sequestrum, involucrum, and the cloacae formation. Sequestrum is the necrotic bone which is present inside the involucrum, and it is a dead bone embedded and surrounded by the infected granulation tissue. Whereas involucrum is the reactive new bone formation which is laid by the periosteum, and that overwhelms the sequestrum in due course of time. But because of the infection in the sequestra part, there has to be some channel through which the necrotic tissue and the dead bone keeps on extruding from the involucrum. So that forms the cloacae, which is the opening in the involucrum through which pus and sequestra make their way out. So in the Viva, you may be asked about the types of sequestrum. That may be tubular sequestrum in the long bone, annular one at the amputation site. There may be ring sequestrum around the pin track of Steelman pin-like, or coke or sand sequestrum may be seen in tuberculosis. Right? There are many colored sequestrum may be found in fungal infections, and Bombay sequestrum may be found in the exposed bone after open fracture. So there is another common asked specimen in the exam. This is a cut open section through the spine where one can see the typical spondylodiscitis of the tuberculosis. So this is a normal looking disc, normal looking body. Here is the the disc portion is all destroyed, and the distal part of this vertebra and the proximal part of this vertebra is also involved in the pathology. In addition, one can see the posterior elements are also involved in the pathology. That makes it a panvertebral one. So from the description point, one must point out that it is a paradiscal that makes his typical appearance, and the loss of vertebral body height and caseating central tissue is also evident. Right? This is a typical appearance, and the posterior element should not be ignored. This sort of specimen may also be there in the exam, where there appears to be obvious gross kyphotic deformity. Rather, the upper vertebral bodies are toppling over the below ones, and there is a severe amount of internal gibbous formation that is compromising the space available for the cord here. And that may lead on to the late onset paraplegia. So the Langhans sort of giant cell, as I have told, that it is not it is a typical Langhans sort of giant cell where the giant cells are located in the periphery in the horseshoe manner, right? And they are also present in other situations like sarcoidosis and the foreign body granuloma also. So it is not a pathognomic feature of tuberculosis. So those students who are having their exam, especially in the southern part of the country, you may find a specimen of Madura foot. So it is a same specimen. It is being seen from the one side as an exterior, and it has been cut open. And from the other side, one may be able to see the interior of the specimen. So foot looks like a tumor, but there will be multiple nodule and sinuses through which multiple circumscribed abscesses and extensive granulation tissue will be visible. Extensive bony destruction is also a pathognomic feature of Madura foot. And this is commonly caused by actinomadura or nocardia. And aspergillus is also likely to cause it. And these sorts of pus containing sulfur granules and these pathology slides, you are not likely to be asked in your exam. So having describing all these common situations that you may be asked in your exam, now I am narrating you the real-time situation because of COVID. Next year also you may not be in a position to be there in a physical exam, or you may be asked in something like OSCE sort of examination. So one must prepare for that angle also. And this is a typical OSCE that you are likely to get in your exam if the exam pattern is based on OSCE, right? So you will be presented. This is a first set of OSCE that you will be asked, and it will be the question 1, 2, 3, 4, 5, or whatever the session demands. And you will find the time and the marks written along, right? So once you will be given a 2-minute time, and whatever marks are there, you will have to focus on the questions that are being asked. Like here, they are asking for the describe the lesion in detail. So you have to write it, and as soon as the time is up, you will be presented with the next set of questions. So you will not be able to go back to your original answer. So one must be very careful while, because if you are mentioning it wrong here, so maybe it is possible that all the next questions you may write it wrong. So here one must be able to see that it is probably a distal femur cut open specimen of a skeletally mature patient, because there is no physis scar that is visible here, and the location is epiphysiometaphyseal. There is an area of necrosis here. There is area of hemorrhage this, and the necrosis here, and cystic appearance is there. The cortices appears thin here, but they are not obviously breached. There is not an obvious pathological fracture that one can see in this section, though it may be present in other surfaces. And the periosteum periosteal reaction, it is not looking like to cause a periosteal reaction. It may be committed that it is slightly eccentric or largely eccentric lesion is there. It is slightly on the lateral side than on the medial side. So these all are the description that you will have to provide here for this thing. And as soon as the time is up, you will find next question. So the next question is probable diagnosis and the differential diagnosis. So from this description, if you are describing it correctly, one should be able to make the diagnosis as a probable diagnosis. First is a giant cell tumor, right? The other less possibilities of the differential diagnosis, if the question is being asked, one must narrate, which may include these sorts of giant cell variants, whatever you feel like that are fitting here, must write here. And as soon as the time is up, you will be presented with the third question, which may be something like that, that what all are the features in favor of or against the malignancy in this specimen, right? So you can write there, since the giant cell tumor is a borderline sort of thing, that there may be few features of benign thing, there may be few features of the malignance in that. So the cortices are thin and eroded, that comes in favor of malignancy. And there is central area of necrosis and hemorrhage, that comes also in favor of malignancy. There is no obvious breach in the cortex, or there are no obvious pathological fracture, that is more in favor of being it benign. And there is a clear-cut area of demarcation, that it is a normal area and this is a tumorous area. So this sort of appearance comes more in favor of benign thing. So one must narrate that features in favor of and features against malignancy in table form. And as soon as the time is up, you may be presented with the next question, which may be something like that, that the enumerate various medical and the surgical options of treatment for the GCT that you must enumerate. So one must not venture out of the question. One must not start writing all the details. What all are the medical? These are the drugs that are likely to cause remission in a case of tumor. And the next one will be the surgical options like a curettage with bone grafting, curettage with autologous bone graft, or curettage with allograft, curettage with extended curettage with maybe other adjuvants also, or custom made mega prosthesis for the distal femur like sort of thing, right? So these all are the things that you just enumerate. Don't write here and there because the time will be limited. The next question may be something like that, that what are the chances of recurrence with each surgical modality. So with the plain curettage, this is the approximate recurrence that one is able to see. Maybe it may is 30 to 40%. And if one is using bone grafting, if one is using the burr, if one is using the adjuvants like liquid nitrogen or the phenol or something like that, so one must be able to just enumerate these things. And so this majority of the time will complete the one session of OSCE there. And I am presenting you another model sort of question or OSCE that may be helpful in your exam. This is another that almost the same, describe the lesion in detail. So it appears that it is a cutout section of a bone mass, probably a case of osteochondroma, which is having a large cartilaginous cap, appears to be a pedunculated one, right? So there is, as far as the surface is concerned, there doesn't look like any obvious necrosis or hemorrhagic areas. And one is not able to see the thickness of the cartilage cap here, because if one is able to see, only then one should comment, because that will go in or against the malignancy. So what all are the features in favor of and against malignant transformation here? So unless we cut it open, we cannot see the thickness of the cartilaginous cap. Rest, there are many features that they are well defined, and there doesn't appear to have any adhesions, and majority of these things will go in favor of it being in a benign pathology. So what all are the chances of it to have a malignant transformation in general population peripheral skeleton, general population axial skeleton, and the multiple hereditary exostosis? So this you should be able to answer from your theory part. And another, what all are the causes of pain in the osteochondromas? So one just enumerate 1, 2, 3, 4 sort of thing, that it may be a case of if the osteochondroma is going into malignant transformation, it may cause pain. If there is a traumatic fracture of the peduncle of the osteochondroma, which may cause pain. Another cause of pain may be adventitious bursitis that may form over it and later on may get infected also. Another cause of pain here may be because of the stretching of the nerves that are in the vicinity of this mass, that neuropathic pain may be present. So these are the common causes of pain one must be able to describe here. So enumerate 2 strategies to decrease the recurrence after the surgery. So just focus on 2, point number 1, point number 2. One has to be quite crisp and clear, and one must go ahead like that. First of all, it may be then one must go for not subperiosteal but extra periosteal resection. The periosteum has to be excised along with this mass. This specimen doesn't look like to have been excised with the periosteum. So another, maybe you can treat the base of the osteochondroma from where it was originating with the several adjuvants that may reduce the chances of recurrence. So this is how you will have to answer it accordingly. Right? So I would like to take any questions if someone is raising here.
Thanks, Sumit. I think you can, yeah. That was an excellent presentation, and to our surprise, the specimens were looking so beautiful for a change. Normally what we get in an exam is a totally distorted sort of a specimen. We just can't make head or tail out of what is being presented over there. So let me tell all the students that this is the new normal. The specimens are going to be on the laptops or on the screen, so there would be pictures, so the clarity would be much greater. So when in our times the clarity was not great, the questions like which bone it is was a very important question. But now if you're not able to localize the bone in these clear pictures, it becomes a real problem. So I would invite both the Agrawals, our guests, Dr. Anup Agrawal and Dr. Hariom Agrawal, to have comments or question on this presentation.
I think very nicely described, Dr. Sumit. As Dr. Lalit said, that it was used to be difficult in our time, but with these kind of pictures, you can really do it. My only comment is that I had seen during my residency also that most of the students used to commit start off right from the provisional diagnosis and hurry up. So you have to really start from the ABC, that look at this jar, as you said from the first slide, and described it mounted or not mounted, like it's the photograph of this location, and unless it is being asked, never jump to the diagnosis. The other mistake students do is they don't say that this is my provisional diagnosis. So that becomes a point of discussion, whether it is provisional diagnosis or final diagnosis, or teacher may cross question you, how did you reach the or confirmed your diagnosis? If you have said just the word diagnosis, should you be able to comment on the color, left or right, or lateral or medial, on just by where you are not able to see the fibula part or the joint part on the distal end of the femur? Should you comment on the lateral and medial side or not?
If one is able to see it clearly, the anatomy of the distal femur is preserved a bit. So one should be able to, like I have shown. Should I share my screen again?
Please, please.
I think that's a very good point by Dr. Anup, that go stepwise. Each step is going to give you marks. So don't jump to the diagnosis straight away. And there are problems at time that in a double bone segment, only the tibia is kept there. So, and if it is only the diaphysis, it's a big problem.
Yeah, this one.
So from this picture, one should be able to differentiate whether, because of this, the lateral part is more or less a straight one, and it is probably a medial one because of this, the distal portion where the vastus medialis is there, the adductor tubercles are there. So one may comment with some suggestion that it is probably, this is probably the medial side and this is probably the lateral side. Though
Perfect.
one,
That was the reason me asking this question, that if you're commenting whether it is medial or lateral, then you should be able to explain thoroughly that why did you comment whether it was medial or lateral. If you will not be able to answer whether it is because of this reason it is medial or lateral, then you are into mess. Probably your marks will be cut for that.
bilkul.
And then another comment, unless until there is a scale on the side, are you supposed to talk about the size of the tumor? Or even if you have a scale, so in your first talk, are you supposed to talk about the size of the tumor also or not?
If the scale is not there along with this, one should rather avoid commenting on the size. But at least the student should be able to tell that it is a case which is going towards the location is epiphyseal going towards the metaphysis, or location is epiphyseal going into the extending into the diaphysis. This much of commitment may be done, but exact size one should be, especially in the pictures. If one is able to see in front of, in the specimen is there, in the jar is there in front of you, you may comment the approximate size without scale, but on the pictures especially you should not comment on the size.
If you have a picture like this, the one which you're showing,
Yeah.
Should you comment on the size or not?
With this, the student can comment on the size if they want.
Thank you. In the spine specimen, I think the common mistake is that because you see the anterior part which is big, you look at all this anterior part, you do not comment on the posterior element also. So I think it is mandatory to comment both on the anterior and posterior element simultaneously once you are describing the whole structure, that it is involving the anterior part, disc and this thing, and posterior part is also involved with such and such description.
Yeah.
Is that so?
Yeah.
Okay. The other thing, can you highlight for all the delegates that what are the telltale signs of malignancy in a specimen which you should look? Because one of the question was that what are the signs which are in favor of malignancy and what are the signs which are favor of benign? So for delegates' sake, can you repeat that? What are the telltale signs which you look for malignancy?
Yeah. So this question is likely to be asked in those specimens which are having few signs in favor and few signs against it. So the classically this would be a case with the giant cell tumor, if not with others. Like here, there is a cortical erosion that one can see, especially on the lateral side. Probably seeing the anatomy, it looks like a lateral side. So there is a erosion that goes in favor of malignancy. There is a hemorrhage that goes in favor of malignancy. There is central necrosis that goes in favor of malignancy. And but there are few features that are in favor of it being a benign one, that it is having a clear-cut zone of differentiation, or the borders are clearly demarcated. That goes because this is abnormal, this is normal. So the zone of transition is quite clearly seen here. So that goes in favor of it being a benign one. There is no obvious breach of the cortex here or the pathological fracture here that may one may say that it is a case of feature of a benign thing.
Thank you, Dr. Smith.
Dr. Smith, it was really a wonderful talk, and I think quite simplified for the PG students. I think if they go through this presentation 2-3 times, then they will feel themselves confident to face the specimen part in their exams. But I want to ask one thing, that after making the provisional diagnosis, examiner is going to ask about how will you confirm the diagnosis. So we will definitely ask you, if you are telling that I will take the biopsy, from which part you will like to take the biopsy. So this is commonly asked question in the exam. So for the PG students, please tell them that while taking the biopsy, it should be taken from which part of the tumor.
Yeah. So this is a relevant question that the student is likely to be asked in their Viva. As far as this specimen is concerned, so the common terminology that one must use while describing the location of taking the biopsy is the tumor host interface. So this is the host part, this is the tumor part. The likely mistake that one may answer in the exam is that you take there is a plenty of tumor tissue lying here, and one can take the biopsy from anywhere. But the better answer will be that I would like to take biopsy from the tumor host interface. So this is the area. This is not the area, because if one is aiming to take the biopsy from this tumor host interface, one is likely to penetrate the joint and can worsen the prognosis of the patient. This is a good area of tumor host interface from which the biopsy should be taken, because the few part of this biopsy, there will be a host area that will be the normal bone, and few part will be the abnormal bone, that will be the tumor bone. So the pathologist will be able to see both the tumor cells as well as and the normal cells, and you will be able to differentiate between the two quite clearly, and the diagnosis will be much more precise. Apart from, if one is taking the biopsy from the central necrotic area, the pathologist may not be able to comment upon the exact pathology, because the majority of the tumor cells would have been lysed there. So
cells are biologically active in the peripheral area.
It is biologically active in periphery also. So one is likely to get the diagnostic material more oftenly from the tumor host interface rather than from the center of the lesion.
Secondly, I want to add a few things regarding the giant cell tumor, just for the simplicity of the PG students, that there are few E's for the giant cell tumor. It's a epiphysiometaphysio lesion. There is a egg shell crackling. It's expansile. It is eccentric. There is a necking staging regarding the activity of the lesion. There is extended curettage done for the giant cell tumor. Oxygen, if not amicable to the curettage, and even distribution of the giant cell tumor, giant cells among the stromal cells. There are few each for the simplicity to remember by the PG students.
Yeah.
Nice one, Dr. Hariom.
Thank you, sir. Thank you.
Dr. Sandeep, anything you want to add or ask?
Yeah, I think I should congratulate Dr. Sumit for a wonderful talk. And what I would like to suggest to all the PG students and all the delegates who are listening to this webinar is that there has to be a systematic approach. This is not a difficult topic. Like other clinical examinations as hip or knee, we make a template and we start from the basics that, okay, this is the first thing I have to tell. This is the second thing. This is the third thing. I think Sumit has wonderfully told that how you should proceed, the location, the nature, the periosteum, the cortex. So if one is knowing all these things, then he will see it and comment it. And that's how you will reach to the provisional diagnosis, number one. Number two, sometimes the examiners are very fond of asking, what preservative do you use for these specimens?
Yes.
Okay. So it's a very, very common question. Now, most of the candidates, they can answer that formalin is the most commonly used preservative. Now, the second question is, why do you use formalin? can you use anything other? So can you, Sumit, tell us about the preservatives? Then I will ask few more questions.
Please enlighten, sir. I will be also enlightened.
I'm just asking. I may. Okay. Now, formalin, I think, is used because it maintains the elastic and mechanical properties of the tissues. It doesn't let the necrosis happen in the tissue, and it maintains the tissue in the same form, whatever you have harvested from the body.
Fixes the tissue.
So, okay, so it fixes the tissue. It doesn't let the decay to happen, and it maintains the elastic and the mechanical properties of the specimen. So I think this is, so the examiner starts from here. So what preservative? Why are you using it? Then the biopsy, they ask it. Then they tell us, show the growth plate. If you are saying it is a immature skeleton, then show where is the growth plate. So these are the few questions, I think, which are very, very common. And only the key is, if you are having a systematic approach, you will not miss anything, and you can answer all these questions. Now, regarding the side, I think if you don't see any feature regarding the side, it is better to omit. Don't say that it is left, right, or medial, because examiner is not expecting. The second thing, examiner never expects you the final diagnosis. If your approach is right, if your findings are right, it is irrespective whether you say it is an aggressive giant cell tumor or whether it is a benign giant cell tumor or whatever it is. So the approach to the case is important rather than the diagnosis. The same thing goes for your clinical examination also. You should know to approach to the case. If the final diagnosis, the differential diagnosis are correct or not correct, doesn't matter. It is the approach. So I think the important thing is that you have not to miss even a single step. You have to go from cortex, periosteum, hemorrhage, necrosis, whether the location, all these things you should mention. And then you can say that the differential diagnosis can be this, but it cannot be confirmed without the histopathological and a smear examination. I think that is the correct approach.
Good, Sandeep, very important tips. Let me give you some more smart tips for the exam. It's a corona time and it's a new normal. So it might not be a bad idea to carry a LED pointer in your pocket. This can be additional in your kit bag because if there is a specimen and you want to point towards something, it looks very messy if you're pointing a finger. So carry a LED pointer with you. One of the biggest problem is you will always get a single bone as a specimen. Even if it is the forearm bone or the leg bone, it will be a single bone, and it becomes very difficult to identify a bone, especially if it is the diaphyseal part only resected and kept. So rather than committing, you can commit that it is very difficult to commit which bone it is. It seems to be a diaphysis. If it is a pediatric one, it could be the femur or the tibia also. If it is an adult, it is likely to be the upper limb. So you might have to go at the size and those things on the description. And then as we do in the x-rays, it is a wise thing to go from the periphery to the center in a specimen. Start describing the periphery and then go to the central area, because it is invariably that you miss out peripheral things which might be glaring in that specimen. And as Dr. Anup asked that question, that how do you sort of support whether there is malignancy or it's a benign lesion, one simple tip is that any resected specimen is going to be a malignant case. So in the back of your mind, you know that it is a malignancy. But then when you are describing this question, try to go from center to periphery. So then you will not miss out things. And most of the things are there within the tumor. You want to describe the margin of the tumor, and then you want to see what the tumor is doing to the bone. And then be careful that if you're a smart candidate, you've done well. The Viva is going to end with this question that, okay, what will be seen? What will be seen in the histopathology? So although you don't have to know the slides now, but you need to have the description of common histopathologies: osteosarcoma, Ewing's, giant cell tumor, and if you're very unlucky, you might end up in a Viva where you have an anatomy specimen lying there. It is not a pathological specimen. It is a dissected anatomy part, maybe the upper limb, and they're going to ask you which is the which nerve, and then the Viva might go into that line. So be prepared for these surprises. And one of the biggest surprises, the brilliant student goes out and he comes out and tells you that GCT is lying and it is of distal end of femur. And when you go in and start describing it, and they have changed the specimen and they've kept a sequestrum over there. And you are totally embarrassed after the whole description that you have described a giant cell tumor of the distal femur, and actually it was the specimen of a sequestrum.
This normally happens. This normally happens.
Yeah, so please see what is lying there. It could be anatomy dissected limb. They could change the specimen, so be very careful. So there are 4 constant questions in a specimen viva. What bone is it? Describe it and try to give us a diagnosis. Do you have a differential diagnosis? And what would be seen in the slide of this case? So any other comments? Dr. Sharad, would you like to add some tips?
One thing you already mentioned, because in my exam many years back, I got an anatomy specimen, and the examiner picked up one tendon. How does it function? What supplies it? And one nerve, and what does it do? So I think we cannot confine ourselves to just tumors and infection. So any other specimen can be given. Secondly, you did mention about biopsy. I think we did have a detailed discussion in one of the tumor programs which we had here. The onco surgeons, they say that we rather go for core biopsies. They do not emphasize so much on the junctional biopsy. They take a core biopsy and take in different direction, 4, 5, 6 cores, and take it, and they're happy with that. So that may not stay, very pertinent at present, that you have to go.
Today's examiner actually wants to know that you won't hit the necrotic area. The MS Ortho examiner wants this answer that you're not going to hit the center of the tumor, which might give you the necrotic area, or you might end up hitting a cyst. So, but if you go to an oncologist, he is very specific. He would plan his biopsy. It will be a core needle biopsy. He would plan it using a CT as well as an MRI, looking at the most representative area and the area which will contaminate the minimum. So I think we've taken almost an hour, and we should wind up the gross specimen part, and thank Sumit for an excellent deliberation. And let's take over the next part of today's webinar, which is on implants. Dr. Amit, could you please share your screen? So implants is a long topic, so we'll cover some part of it today, and the rest of it in another webinar. So I suppose Amit is going to tell us about plates, screws, and nails today. Over to Amit.
Good evening, everyone. And
full screen.
Yes, sir. Good evening, everyone. I first want to thank DOA for giving me this opportunity. After this elaborate discussion over specimens, first of all, I would just like to tell all the audience of this session that specimens are a bit different from implants, because implants you are expected a bit more than specimens, because this is a thing which you are using day in, day out in your life. And the level of question can vary from just a basic question, that what is the implant, to what the principle of the implant is, what are its pros and cons, and then showing you the X-ray along with it. So the question may vary from basic to the advanced. So each slide of mine holds some or one of the relevant question which can be asked in the examination. So to begin with, we will start from the screw. So this is again a definition, can be asked in the examination. Few examiners are fond of asking that, okay, how you define a screw? So it appears to be a simple device, but it is a combination of simple machines. A screw is a mechanism or a machine made up of a piece of metal with a threaded surface and a point on one end and a slotted head on other end that is twisted to penetrate and fasten two things together, and converting your rotational torque motion into a linear motion. So that is what is the definition of a screw, although it's complex, but you can define like this. And this is just a broad picture to show you how the screws look like, and how a drill bit looks like. On the top of the screen, you can see a drill bit, then some screws, and then one of the instrument, which is a tap. I'm going to take this in detail. So this is a screw. If you can see in detail, it has many parts. And each part of the screw is important because it will be asked in the examination. So to see in more detail, this is a screw in which it has a head, it has a countersunk. So you can appreciate that this is a head which basically attaches to the screwdriver. Then this is a countersunk part. Then this is the area run out. Then there are threads. Then there is a tip. And it has two different diameters. One is a minor core diameter, which is a solid one. And then the outer core diameter, which has a threads. Basically, the threads are made over this core diameter. All right. So the first, going into some salient features of each part. So first foremost is the head. So head engages with the screwdriver. And the most important thing which you should keep in mind in your clinical practice is that you should keep in mind the size of the screw which you are using and the type of slot in the head, especially when you are planning a screw removal. Most of the companies usually provide a hexagonal type of head of the slot in the head, but there are different slots available like star drive, etc. So you should keep these things in the mind and you can answer accordingly in the exam after seeing the slot. Some other salient features of other parts of the screws like countersunk, as I have already shown you that it is an undersurface which can be conical or hemispherical. Conical undersurface used for compression effect, usually used along with the plates like dynamic compression plate, which I am going to cover later. And hemispherical are a different shape, but they have advantage to be angulated in all the direction, and they can increase the angulation leverage which a screw can provide you while applying in the plate. Then shaft is a smoother area between the head and the threads. So going back to this area, so shaft is something here. This is smooth area between the threads and the head. Runout is a transitional area between shaft and the threads. And to tell you, torsional strength of the screw usually varies with the cube of its root diameter of the core diameter. That is, root diameter is a core diameter, and tensile strength with the square of the same diameter. What I want to say is that the strength at which the screw is going to break, it depends on the core diameter of the thread, not the outer diameter. So the diameter by which you are identifying the screw in your OT, like 4.5 mm, this is not the diameter which is going to describe the torsional strength or the tensile strength. It is a core diameter of the screw. So 4.5 mm screw, the core diameter is 3.5 mm. All right. Okay, coming to another important part, which is the pitch or the lead. Pitch and the lead, it is a distance between the two adjacent threads of the screw. And pitch is the distance between the two threads, and lead is how much a screw travels after completion of one rotation. So which is equal to the pitch. That's why I mentioned them simultaneously together. So cortical screw usually have a smaller pitch of around 1.7 mm. So this is again becomes a question asked in the examination. And cancellous screw usually have a larger pitch, that is 2.75 mm. And that's how you can differentiate between a cortical and cancellous screws also, by identifying whether your threads are placed close to each other or they are placed far away. Outside diameter usually affects the pull-out strength. So there are two types of strength. One is a breakage strength, which is a torsional strength, something like that. And one is a pull-out strength, how easily the screw can get out of the bone. So that is basically defined by the outer diameter. So a bigger diameter, and if there is a difference between a thread diameter and the core diameter is a big difference, then the pull-out strength, the threads are engaging well in the bone. So the pull-out strength usually increases. All right. Then there is something known as flute or thread cutting device. I'm going to show you in the real picture also. So this is a small cut or the sharp cutting edge present in the screw at the distal tip, which is basically used in a self-tapping screws. I'm going to tell you what are these screws are. So this is just a variety of use of screws in orthopedic practices. These are the different drill bits. By convention, to differentiate easily in the operation theater, the locking screws drill bit are made longer, in longer size, to easily differentiate during the surgery. Otherwise, you have to read the size of the drill bit to differentiate between different types of drill bits. All right. So this is to identify in the examination. These were drill bits, and then this is a drill bit over the battery drill. All right. This is a tap. So the normal convention to put a screw is that you have to first drill a hole inside the bone, and then you have to tap. Tap means you have to make the threads inside that bone, because if you see this drill bit, this is not going to make the threads. This is just going to make a drill, a hole inside the bone, because the threads are not there in the drill bit. It has sharp angles to make the hole. But now if you visualize this tab, this has fine threads, and these threads are actually equal size to the threads of the screw. So this tab is a sharp threaded material which makes the threads in the or makes the grooves in the bone over which you can put the screw. So this is known as bone tap, T-handle shape, and it has threads at the end. This is a screwdriver. These are again different types of drill bits. If you can see that this is again to show you the tap, the closer version of the tap, how the taps looks like. And one of the major question asked during the exam, that how you conventionally should put a tap. So the conventional procedure to put a tap is that you should put 2 rounds at least conventionally in the clockwise direction, and then half a turn anti-clockwise direction to remove or disengage the bone removed by the tap. So if you can see these threads, so these threads are basically remove the bone, and then this is an empty space in between the tap, which basically the removed bone gets accumulated between this area. So after putting 2 threads continuously in the 2 clockwise rounds, circle round in a clockwise direction, you should rotate in anti-clockwise direction half a circle to just disengage the stuck bone in this area. All right. So this is a conventional question, but usually we in orthopedic practice don't use this type of practice, and that's why we usually fail to answer this kind of question. So this is a normal solid drill bit, and this is a cannulated drill bit. As you can see, there is a hole in the drill bit. And this is another instrument kept on the table, which is a depth measuring device, because you have to measure the size of the hole you have made so that you can appropriately put the size of the screw. So there is another question, that when you are going to put this depth measuring depth measuring device during the process of putting the screw inside. So sorry, you have to put this depth measuring device after drill bit, not after the tap, because it is said that first you drill the hole, then you measure it, and then you make the threads by the tap. If you measure the depth of the hole after tapping, so it is said that while measuring the size of the screw, you usually damages the threads made by the tap. So that is a conventional sequence. So these are the drill sleeves which are used. So there are different drill sleeves. One of the first drill sleeve is a commonly asked drill sleeve, which is a compression drill sleeve. Why it is known as compression drill sleeve? If you can see, it is usually available in 2 colors, blue and yellow, and one of the side is a compression side, and there are different sizes also. If you can see, here is embark 3.5 and 2.5. Moreover, there is one side is a compression side. And what do you mean by compression side? I'm going to deal later also how to achieve compression by using plate. But compression side means if you are using this yellow side, then you have to keep, there is an arrow here, you have to keep arrow towards the fracture, so that your screw placement in the plate will be such that you could able to achieve the compression. And that screw placement is known as eccentric screw placement. So the screw is placed away from the fracture site, but if you are using a drill sleeve to drill the screw hole, then the arrow of the screw hole, the drill should be towards the fracture site. So this is a drill sleeve, and this is a tap sleeve. If you can see, it has a serrated ends. It has a serrated ends, and it can be used as a drill sleeve also, especially if you are using without the plate, without any plate, and you want to just fix your drill sleeve over the bone directly. So you can use this serrations to engage this drill sleeves over the bone. So this kind of sleeves are usually used for tapping the screw hole, or if you are using to put a screw without the plate. All right. Then this is a third sleeve, which is a locking drill sleeve. All right. This locking drill sleeve has a specialty. If you can see, this has some threads over the end, which basically engage with the threads of the plate. I'm going to deal it later how the locking plate looks like. All right. So this is a locking sleeve in the end, and this is a normal tap sleeve or a sleeve of the drill bit if you are using on the bare bone. All right. So these are the normal sizes which are again asked in the examination. So the students should be mainly concerned with this middle column, that for the screw size of 4.5, the drill bit used is commonly 3.2. The screw size of 3.5, I'm dealing with the outer diameter, because the 4.5 screw size, the core diameter is 3.5 around. So the drill bit 3.5, 3.2 to 3.5, the drill bit for the thread hole is 3.2. So the drill bit size is usually decided by the core diameter of the thread. All right. So that it is confusing. That's why asked in the exam. So 4.5 screw, then the drill bit is 3.2. 3.5 screw, the drill bit is 2.5. 2.5 to 2.7 screw, the drill bit is 2.0, and 1.5 screw, the drill bit is 1.0. Then there is a different hole, which is a glide hole, which is a principle of lag screw. Putting a lag screw, how to achieve compression with the screw. So we have to make two types of hole. One is a thread hole, one is a glide hole. So the glide hole drill bit is equal size to the outer diameter of the screw, because we don't want the proximal cortex to take any purchase, to take any hold to achieve that compression. So that's why the glide hole drill bit has an equal size to the screw size outer diameter. So these are some different types of screws shown to you how the core diameter is a bit different from the outer diameter. For example, we are dealing with a cortical screw with a different company, with a different make. The inner diameter of a 4.5 mm screw varies from 3 to 3.5. All right. The 4 mm cancellous screw has an inner diameter of 1.9, and 4.5 mm cannulated cancellous screw has an inner diameter of 2.7. So depending on the different inner diameter, you have a different drill bit size. All right. So now coming to this identification, as I've already told you that whole of this presentation will be like OSCE, and definitely there will be OSCE at the end also. So you will be asked like this, that what you are dealing with. So if you can see in this screw, the first screw is a self-tapping screw. How you are identifying is, if you can appreciate at the end, there's a sharp end here. And the sharp end basically is a flute. If you can appreciate, this is a flute, the grooved part. So you can decipher that whether you are dealing with a self-tapping screw or you are dealing with a normal cortical screw, which is a non-self-tapping. So if you can see the non-self-tapping screw, the tip is quite blunt. All right. And other parts are as it is, like the head, like the countersunk, like the shaft. This is a shaft part. Then the runout part is just at the transition between the shaft and the threads, and then these are the threads, and then this is a flute in the self-tapping screws. Self-tapping screws has the typical characteristic that you don't want to use tap, and they can be used without the tap. So this flute, basically the sharp tip basically makes the taps and drives itself inside the bone, and this flute cuts down the threads before the threads engages with the bone. All right. So this is how you are going to differentiate between a self-tapping screw and the cortical screws. Then coming to, these are the two different types of screw. If you can appreciate, now these are the two different things. If you can appreciate easily, the threads are quite bigger than the core diameter. The core diameter, the threads are quite bigger. The distance between the threads is also quite high in comparison to this type of screw. And there is another difference, that is the tip. If you can see, this is a blunt tip showing you this is a normal non-self-tapping cortical screw. This has a different tip. This is not blunt. This is a sharp tip, which is a cork screw tip. So this type of screw is usually known as cancellous screw, made for cancellous bones. All right. So you will be shown a screw in the examination and will be asked that why you are saying this is a cancellous screw. So you have to tell these three differentiated special features. First is that it has a more pitch than the conventional cortical screws. The diameter, the difference between the outer and the inner diameter is higher. And why it is made so? Because cancellous screws basically are meant for the cancellous bone. And if you see the bone by and large, for example, a shaft of femur. So the cancellous bone, there is a large, huge metaphyseal area which takes down the stress. So the break point of the screw is not that much important for us, although that is also important than the pull-out strength, because cancellous bone is weak in that sense because the screw can get out. So we try to increase the pull-out strength of the screw. That's why the threads are quite large than the core diameter. All right. Although it is again a wrong convention that cancellous screws are very weak, it is not like that. They are also stronger. All right. So this, and then the tip. The tip is a cork screw tip. And this cork screw tip is again special because cancellous screws again don't need any tap while putting in. So please don't use any tap, just drill it and insert the screw directly, because this cork screw tip makes the threads automatically and makes its own way. And basically it is not making the threads. The cancellous screw doesn't make the threads much. It displaces the soft cancellous bone and makes its own path. All right. Conventionally, it is also known as wood screw. So can be asked in the examination, okay, what is a wood screw? So wood screw is nothing, basically a screw which makes its own path and displaces the softer bone. So this is a wood screw, and the machine screw is which does not displace the softer bone, and it needs a tap or something like that to make the threads inside that hard bone. So that is how a wood screw is actually the cancellous screw, and a machine screw is actually a cortical screw. So this is a normal cortical screw. I have told you three differences and will be asked in the examination as question 1, 2, 3. All right, coming to the next question. So this is on the left side of the screen. You can see this is a simple, fully threaded cancellous screw. So there are threads which are available from top to bottom. It is a fully threaded cancellous screw, and shaft is there, runout is there, and the countersink is there. This is a partially threaded cancellous screw or the shaft screw. Another question asked with this, why these screws are known as shaft screws? So as you can see, the shaft area, what is the shaft? Shaft is a plain area, smooth area between the threads and the head. So the shaft area is quite long in this screws. So this is known as shaft screw. And the benefit of this is that they can directly achieve compression, because as I have told you, when you are trying to put a lag screw, what it does, what is a lag screw? When you are trying to achieve compression using the screw at the fracture site. So the principle of the lag screw is to take a good hold on the distal part of the fracture and not to take any hold on the proximal aspect. So if you can see, the proximal aspect will be the shaft area, which is smoother, and it will not take any hold, and the threaded part will definitely engage very hard in the bone, and it will provide a lag effect. So another benefit of this shaft screw is, if you can appreciate, the core diameter of this screw is smaller in the area of thread, but the diameter of the shaft is quite large. All right. So the diameter of the shaft is quite large, and it is equaling to the outer diameter of the screw, which again increases the breaking torsional strength of the screw. So these are the two benefits of the partially threaded cancellous screws, or commonly known as shaft screws. So this is again shown a partially threaded screw from the end-on view. partially threaded cancellous screw you can see from the bottom, and this is a solid screw. And obviously you can appreciate that this is a cannulated screw having a hole inside the screw. Few people says that cannulated screw, because they are not made up of metal completely, they are weaker than the solid screw. But it is not the correct fact and can be asked in the examination. Because the diameter, because usually the cannulated screws have a hole of 1.6 to 2 mm to pass for a guide wire. So the core diameter is quite more than the solid screw. So this compensates, the increase in core diameter compensates for the loss of this metal for the guide wire. So the strength is comparatively similar of a cannulated screw and a solid cancellous screw. So these are cannulated screws 7 mm. The diameter is quite high, quite more. I will show you 4 mm also. And the difference is 32 mm the thread, the length of the threads. This 32 mm thread length is, this is a 32 mm thread length and this is a 16 mm thread length. So these are two different thread lengths which are used especially in 7 mm, especially in fracture neck of femur. If you are dealing with a subchondral fracture, subchondral I am saying, if you are dealing with a capital fracture, subcapital fracture of a fracture neck of femur, just proximal and very close to the head, so you are going to use these 16 mm threaded screws. So you may be shown two types of screws and you will be asked that when you are going to use a 16 mm threaded 7 mm screw. So 7 mm is the diameter of the screw. The drill bit which you are going to use is a 4.5 mm, and moreover the 16 mm is the length of these threads. So you will be asked in the examination when you are going to use this 16 mm screw. So you will say that when the fracture line is proximal, you are dealing with the capital fractures, subcapital fractures, not the transcervical or not the pachycervical, subcapital fracture. So you don't want those screw threads to go at the fracture site. So you are going to use the small screw threads. So the X-ray shown here is using the smaller screw heads, that is the 16 mm. All right. So on the side to side, you could able to appreciate that this is a 7 mm screw and this is a smaller side which is a 4 mm screw, and this is a washer used, and this is a washer for 4 mm, and washer has one of the surface is concave and one of the surface is flat. The flat surface should rest on the bone. The concave surface is to accommodate the countersunk area of the screw. All right, so this is 7 and 4 mm, and 4 mm is commonly used in the medial malleolus fractures, all right, or the smaller areas, and 7 mm is commonly used for the fracture neck of femur. All right, coming to the malleolar screws. So malleolar screw is a different screw. The difference is that it has a thread diameter of 4.5. So this is not the common screw which we usually use in malleolus, which is a 4.0 mm cannulated screw. This is a malleolar screw which has a trocar tip. The tip is not cannulated, it is a solid screw. The core diameter is 3.5. It is a different drill bit used. The glide hole, if people are trying to achieve the compression, then glide hole from the 3 mm drill bit, and the trocar tip which displaces the bone. So the difference between a normal tip and the trocar tip is that trocar tip usually displaces the bone and doesn't make the threads completely. So again, this is the difference between the malleolar screw and the normal 4.0 cannulated screws. So this is how it looks like, and the core diameter is quite high and the threads outer diameter is less. As I have told you, the core diameter is 3.5 mm. This is not the usual case for the 4.0 cannulated screws. So core diameter is high, and this is the usual shape. This is a trocar sharp tip like the olive wires which we are going to use in the Ellis arrow, and this is how it looks like. Okay. This is another screw. I hope you could people identify this. This is commonly known as Hubbard screw or a headless screw. How to identify this? This has threads on one end, threads on another end, and there is no head. And this is beautiful and this is wonderful orthopedics machine to achieve compression, because the diameter here is different than the diameter in the distal part. So diameter on the proximal aspect is 3.9 mm, and the pitch is also different, and the diameter of the distal aspect is 3.0 mm, and the diameter of the shaft is 2.0 mm. So you drill the hole with the 2.0 and then you thread it, and you achieve the compression by the differential motion between the proximal and the distal aspect of the threads. And there is another benefit that you could able to use this screw intra-articular fractures if you want to put the screw through the cartilage side, because you don't want the head of the screw to be prominent over the cartilage. So you wish that this part should be completely within the inside the cartilage area, so that there should be no arthritis due to prominent head of the screw. So this headless screw is beneficial. All right. Okay, so this is the Herbert screw and the headless screw as shown, used in the intra-articular from the intra-articular area, commonly used in the scaphoid fracture, again commonly used in the intra-articular fractures like distal femur or like intra-articular fractures around the elbow, especially intercondylar fracture of the humerus. All right, so this is Herbert screw. Coming to the bolts, these are kept in the exam to confuse the students. These are bolts and usually ask what is the difference between the bolt and the screw and where they are used. Usually the bolts are used to interlock the nails. All right. So this is a bolt. If you can appreciate the thread diameter and the core diameter, there is no difference at all, because the main purpose of the bolt is to engage the nail and prevent and increase the torsional strength of the bolt or the locking mechanism, so that they should not break easily. The pull out there, the purpose is not to increase the pull out strength. So the tip is again the trocar tip. It does not make any threads in the bone, and they can be hammered easily, and that's what you have done or you have seen your seniors doing. At times they may be hammering the bolt, all right, may not be screwing them, because they are not putting any threads inside the distal inside the bone. They does not press the bone, they just and transfers more of the bending forces, and the core diameter is quite thick than the conventional screws. So this is the difference between a bolt and a normal screw. All right. Okay, so this is another type of screw. If you can see, I hope you guys can easily identify this screw. This is a self-tapping screw because this has a flute at this end. I hope you can examine it and identify it. And this is a different type of screw. It has a flute. It is also self-tapping. It has some threads. The threads are not very larger in comparison to the core diameter. They are placed very close to each other, and it has some threads in the head also. So this is a different type of screw known as locking screw, and the identifying structure is that this has a threads in the head of the screw also. All right, this doesn't have any threads in the head. So if you are getting any screw in the examination, it has a threads in the head, so you are straight away saying that okay, you are dealing with a locking screw. Then you are going to tell that locking screw has a lesser pitch than a normal cortical screw. The locking screw has the difference between the core diameter and the outer diameter is again less in the locking screw in comparison to the cortical screw. The flute is present like the self-tapping. So it means that all the locking screws are self-tapping screws, and there are threads in the head. These threads are basically going to engage themselves with the locking screws of the locking holes of the plate. I'm going to show you how the locking plate looks like later. All right. So this is a self-tapping screw. Coming to the plates. So here we ends the screws. The screws are important part of the plate. That's why I covered here. Coming to the plates. These are the armamentarium orthopedic surgeon have even more. I've just taken this photo in the OT just to show that there are lots of plates, and they are ever evolving plates, the anatomical contour plates, and then they are plates with the periprosthetic fractures, and anything can be kept in the examination depending on the center which you are going ahead for the exam. But by and large, the plate usually the plate usually form mainly the DCP, the reconstruction plates, the semi-tubular plates, the LCDCP, the LCPs, and the LIS. These are the commonly plates available, and these are the common principles which are asked in the examination. So to identify this kind of plate, if you people can identify, this commonly is known as dynamic compression plate, and this is one of the first plate which is commonly used in the orthopedic practice and is still used commonly. Although there are lots of plates earlier evolved like round plate, fish mouth plates, and different types of plates, but they are now obsolete. But this is a plate which is commonly used nowadays also. If you can see the characteristic feature of this plate, that the holes are not evenly distributed. There are 2 holes here, the 3 holes are there, and in between there is a large gap. In a larger size plate, you have staggered holes also like this on a different planes. All right. So it was first introduced in 1969 by Dennis. A revolutionary concept of compression plate featured a new hole design for the axial compression, and it has a broad or the narrow. The broad DCP is usually used for 4.5, which is a 4.5 mm screws, and usually used for femur. The narrow DCP is again uses a 4.5 mm screw, but usually used for humerus and tibia. And the conventional DCP, the smaller DCP, which uses a 3.5 mm screws, are usually used for forearm, fibula, pelvis, or clavicle. So to identify, this is a narrow 4.5 mm DCP, a larger screw holes are there. To show you underneath, it has a very smoother surface, very smooth surface. All right, completely smooth. And again, there is a distance in between the half of the plate. The plate is divided into 2 halves. All right. So the earlier which I showed you, this is a broad DCP. All right, 4.5. This is a conventional DCP, 3.5 mm. So this 3.5 mm is commonly used for forearm fractures. This is commonly used for femur fractures, and this is commonly used for humerus fractures. All right. So this is the difference between that. Can be asked in the exam, what is the width of these plates? So the width of these plates are, the smaller conventional DCP is 11 mm. The profile is the thickness. The thickness of the plate is 4 mm. And the screw usually used are 3.5, but a variety of screw can also be used like 2.7 or 4 mm. The narrow DCP uses a 4.5 mm screws. The size of the screw, the size of the plate, width of the plate is 13.5 mm. The profile is 5.4 mm, and the broader DCP has a profile of 7.5 mm, and the profile, the width is 17.5 mm, and the profile is 5.4 mm. The thickness of both the narrow and broad DCP is same, and the screw used are also same. All right. So this can be asked in the examination. What are the problems with the DCP? Why we moved ahead for the DCP? The problem is that if you can see, the design is, it has an extended central region. The screws are staggered. So if you want to put a screw as close to the fracture site to increase the working length, to decrease the working length of the plate, so it is not possible with the DCP. So this was a disadvantage. Then because the under surface of the DCP was completely smooth, and it get stuck, attached to the bone very close and in a very tight fashion, so the periosteal vascularity gets compromised, causing osteoporosis of the underneath surface of the bone, and that makes it a more problematic situation and a stress shielding effect and a chances of peri-implant fracture. And if you remove the plate, then you will see just the papery thin cortex beneath that plate. And then the angulation allowed. So the DCP, conventional DCP, the staggered hole DCP, they allow only 25-degree angulation of the screw in the longitudinal plane and 7 degree of angulation in the transverse plane. All right. So the angulation. So if you want to put a oblique screw, you could not able to put that oblique screw in the DCP. All right. So what comes is the next plate, which is LCDCP. So if you can identify now, in this plate there is no in between area. All the screws are equally distributed along the plate. And if you can see the underneath surface of this plate, there is some trapezoidal area which are cut under the surface of the plate between two screw holes. These trapezoidal area basically decreases the contact area of the plate with the bone and prevents the vascular damage of the periosteum. All right. So this is known as limited contact dynamic compression plate, or commonly conventionally known as LCDCP. All right. So this unique shaped undersurface makes the limited contact with the bone and thus preserves the blood supply. Limited contact dynamic compression plate. Now coming to the compression principle, can be asked in the examination. So this is how compression occurs in either LCDCP or DCP. So if you see those holes of the plate have slant in them. This slant and the countersink area of the screw is also conical. So when you tighten this screw, and one of the screw you have already tightened in the plate, first you tighten the plate one end and then you tighten the other screw. This screw basically with the axial force tries to make its position between the hole. And when it tries to make the position between the hole and you are trying to push the screw hard with the torque of your hand with the screwdriver, this area of the screw head basically pushes against this area of the conical or the slanted area of the plate and moves this complete plate in this way, in this direction, the arrow. So the complete construct of this screw and the plate moves towards this screw, and hence the compression is achieved. All right. So this is how the compression is achieved and in the dynamic compression plate, can be asked in the examination. And when you are there are 2-3 ways how you can achieve a compression. One is a lag screw, then this is a dynamic compression plate, and then you use a Muller's compression device. Usually nowadays we don't use it because that increases the dissection and that increases the skin exposure also. Muller's compression device can also be kept in the examination. I have not put it in the presentation, but you can see how it looks like, Muller's compression device. And the other way to achieve a good compression is pre-bending of the plate. So if you are pre-bending the plate to achieve a compression on the far cortex, so one of the principles given in the books is that you have to put the near cortex screw first to achieve the good compression. All right. Okay. So now coming to the next set of the plate. So if you can appreciate what this plate looks like. So this plate looks like a combination of a dynamic compression hole which has a slant here and a combination of another type of hole which has some threads in the plate hole itself. So as mentioned earlier, these threads are basically meant to engage one of the screw known as a locking screw. And the principle of locking screw is a bit different than the normal screw. So the normal screw purchase in the proximal cortex, in the near cortex and the far cortex, and provides strength to the construct. And the proximal cortex purchase provides around 80% of the strength, and the far cortex purchase provides around 20 to 30% of the strength to the whole screw plate construct. That's why it is said the optimum length of the screw in the normal plate should be that at least one thread should be crossing the distal far cortex. Coming to the locking screw basically works on different principle. It works on something known as internal external fixator. So if you see the external fixator basically makes the whole constructs in such a rigid way that it does not allow any micro motion to the bone and fixes bone very rigidly. So what it does that as soon as you put the locking screw here, so this locks with the plate and with the proximal cortex. It takes purchase in the proximal cortex and locks with the plate. It does not sticks the plate or compresses the plate with the bone. So the benefit of this locking plate, one is that it prevents the vascularity. The second benefit is that in osteoporotic fractures, when you are suspecting that the bones are weak, it increases the stability because it is basically providing the full and final stability from the proximal cortex only, and the stability at the screw plate junction by firm grip of the screw over the plate by threading the screw heads, the threads in the head of the screw and the threads in the plate. And in osteoporotic bone, it is advised that you put these threads inside the distal cortex also. So this is a locking, the plate is locking compression plate. So earlier in the evolution of the plate, the plates came as a locking plates only. Because as I've told you, good benefits of the locking plates. So earlier what happens that only locking plates comes in the market. But there becomes another problem, that because this is very rigid implant, that it does not allow even a micro motion at the fracture site, and we could not able to achieve compression at the fracture site. So what a modification we did in the implant is that a combination plate was made, the locking compression plate. So the locking plate has threads in the hole for the locking screw, and the compression hole can achieve compression at the fracture site and can make the plate attached to the bone closely. So you can first make the plate closely attached to the bone and achieve compression, and then you can make the implant more stable and rigid also by putting some locking screws, especially if you are dealing with the osteoporotic fractures. So coming to the fixation principles, so these are the main plates which are available in the market and the principles which you will be asked in the examination. Coming to some fixation principles, the anatomical reduction of the fracture fragment, stable and rigid fixation, not rigid, mainly the stable fixation, early movement of the patient. And how it works: screw tighten plate to the bone, generate compression, screw threads in the bone under a load applied intraoperatively. Patient load add to the amount of preload on the bone, plate screws construct. Plate relies on the absolute stability for primary healing. Anatomical reduction of the articular surface should be done. Stable fixation should be achieved. So the lock plate are usually used, especially in the osteoporotic fractures and the intra-articular fractures, because you want absolute stability intra-articular fracture, because you want to provide immediate post-operatively rehabilitation. So you want a rigid construct there. So you use a lock plate. So all the anatomically recontoured plates, contoured plates available in the market, they have locking screws distally, not the compression screws, to achieve a locking holes. All right. Careful handling and preservation of the soft tissue and blood supply. And as I've already told you, what are the fixation principle of lock plates are: screw lock to the plate, screw inserted into the bone with minimal axial preload, no stress in the system prior to the patient load, plate is not compressed to the bone, hence reducing the construction of the blood supply. So this plate is not compressed to the bone because prior to compression to the bone, this screw head engaged in the threads of the plate, all right, because it is engaging with the locking screw. Does not reduce or align the fracture. So this is a disadvantage of the locking plate, because it does not reduce the fracture. It cannot compress, it cannot align the fracture. This plate simply acts as a splint, relative stability for secondary healing and callus. A long plate and adequate spacing between the locking screw can act as a bridge plate also. Bridge between the two fracture ends when you don't want to interrupt the in between fracture sites, so it can act as a bridge. The longer the plate, the better it is. All right. So biomechanical and clinical benefits of the locking plate is the plate and the screw form of one stable system. Stability of the fracture depends on the stiffness of the construct. Locking the screw into the plate ensures angular and axillary stability, eliminates possibility for screw toggling or loosening, decreases the risk of post-op loss of fixation. But the problem with such kind of fixation is, or such kind of screw is, that not much of angulation is available while putting these screws. So although there are variable angle locking plates are available nowadays, in which you can angulate the screws also for 15 to 20 degrees, but the direction of the screws are predetermined. All right. So locking screw do not rely on the plate bone compression, but function similar to multiple small angled blade plates, osteopenic bone, comminuted fractures, other areas where traditional screw fixation may be compromised. You have the ability to lock the screw in the fixed angle construct. Improved biology for healing bridge fractures, does not compress periosteum, does not disturb the fracture hematoma. I'm again and again emphasizing, because locking, if you are asked about the benefits of locking, usually the student is stuck up on the one thing only, that okay, it is used in the osteoporotic fracture. But the other thing is the student usually forgets. All right. So modes of application usually asked in the examination if your Viva is going on the plates. So the one of the mode of application is neutralization, in which it only neutralizing the external forces of the muscle pull and the other forces. All right. So neutralization plate usually put along with a lag screw. So the lag screw achieves the compression, and then you put the neutralization plate, 3 cortices, 3 screws on one fragment, 3 screws on the other fragment, 6 cortices on the one side, 6 cortices on the other side conventionally, and then you neutralizes the other forces. So this is another question which is asked: how many screws you are going to put in which bone and in which fragments? So conventionally, the minimum screws which are put on one fragment, each side of the fracture, is 5 to 6 cortex in radius and ulna, then 6 cortices in humerus, at least 6 to 7, and then 6 to 7 cortices in tibia on one side. I am saying one side, and cortices, I means 2 cortices means 1 screw, the proximal cortex and the distal cortex, the near cortex and the far cortex, and 7 to 8 cortices at least in the femur bone. Then compression mode of application, when you are using the plate in the compression mode, especially the dynamic compression plate or the LCDCP, limited contact dynamic compression plate. Then the buttress mode, it is a different mode in which you buttresses the fracture fragment. What do you mean by buttress? I am going to tell you next. And then there is a bridge plate. As I've already told you, if you are having a severely comminuted fracture and you don't want to interrupt the blood supply of the fracture fragment, and you believe that I am not going to achieve that reduction in that comminuted fracture, so you can bridge the whole construct by bridging mechanism. So that plate act like a bridge, and you put the plate in a minimal invasive manner. You put a distal incision to the fracture, you put a proximal incision to the fracture, and just slide the plate distal, proximal or distal, starting from proximal or distal to the other end, and put screws proximally and distally without compromising the biology of the fracture and hematoma. All right. And there are some other plates like tension plate, or that applied on the tensile surface of the bone, which is a convex surface of the bone. And then there is another plate which is anti-glide plate, which anti-glide plate is a bit different from the buttress plate. These are the T and the L plates. A larger plate, 4.5 mm screws are used, shown in the examination, usually used for the tibia fracture, proximal tibia fracture, or the distal femur. Earlier used, but with the invent of anatomically contoured plate, these are less often used. But if you want to use these plates and reduce the expenses of the patient, you can use this conventionally available plate. And these are the buttress plate. They work by the buttress function. And these are the T plates, and this is a L plate on the basis of shape, 4.5 mm screw. These plates are nowadays available with the compression, on the normal cortical screw of the plate and the locking screws also. This is how the buttress plate works. And how the buttress plate works, then the longitudinal axis of the plate, the force of the plate is perpendicular to the longitudinal axis of the plate. So for example, you have a shear fracture like a volar Barton fracture. In a volar Barton fracture, this whole of the fracture moves anteriorly, all right, volarly. So this plate just presses the whole of the volar displaced fragment posteriorly. So the direction of push of this plate is perpendicular to the longitudinal axis of the plate. So this is how it buttresses. Buttress means that the reduction element. So how it is different from the compression plate? The compression plate, the DCP, the compression of the fracture fragment, the linear compression of the fracture fragment is along the long axis of the plate. But in the buttress plating, the compression of the fracture or the reduction of the fracture is brought perpendicular to the direction of the long axis of the plate. This is how you have to define the buttress plating. All right. Then this is a 1/3 tubular plate commonly used in the exam, given in the exam, and usually used nowadays also in fibula fracture. And commonly used, the principle commonly used for the fibula fracture is the anti-glide, especially for the oblique fractures. And what we usually do in the anti-glide mechanism or the principle is, when you are dealing with the oblique fracture, you just put a screw just proximal to the oblique end of the fracture, which will prevent the gliding of the fracture end. You may not need to put any screw distally, although in this diagram we are putting some screws also, but I am just trying to tell you what is the anti-glide principle, that you put a screw just proximal or distal to the fracture end according to the obliquity of the fracture. All right. So this is a 3.5 system, 1/3 tubular plate, or a 4.5 system, similar tubular plate are also available. They have a limited stability, very weak plates, very thin plates. They have collared holes, usually used in lateral malleolus, distal ulna olecranon, and distal humerus. Then there is another plate kept in the examination, which are recon plates, 3.5 or 4.5 mm recon plates, deep notched between the two holes. How to identify? They have a notch between the holes. All right. So there is a hole and there is a notch between the hole. LCDCP has a notch or the trapezoid cut on the under surface, but these recon plates have a notch between the holes on the medial and the lateral surface of the plate. So they have accurate contouring. So the benefit of these plates is they can be contoured easily, because the coronal movement of the plate can be done easily by these holes. So these holes are made deliberately to reduce the bending strength of the plate, so that they can be bent easily. All right. So they are used where the bending is required, like pelvis, acetabulum, distal humerus, clavicle, and olecranon. So the benefit is there. So you will answer like that. And these are anatomically contoured lock plate, as I've already told you, different locking, like this is a Philos plate, and there are different, this is a distal femur plate, and there are different variety of plates are available. So you must check with your implant guide to show you all the plates, so that you may not miss out any available latest plates. Coming to the DHS, this is a common plate covered in the plate only, but I am just covering the basic principle of DHS in a minute or so, because I have to cover the nail also. So just to identify the DHS barrel plate, this is a barrel, this is a barrel, and this is a plate. This is known as barrel, which is available in two lengths, the small barrel and the long barrel. The long barrel, the length is 38 mm, the small barrel, the length is 25 mm. Then this is a DHS angle guide, 135-degree angle guide, although there are various angle guides available, but the conventional angle guide which is available is a 135-degree, which is the normal neck shaft angle of the patient. And this is a DCS, a different plate, dynamic condylar screw blade plate. Oh, sorry, not a blade plate, dynamic condylar screw plate. And if you can see, the angle guide is different. It is a 90 to 95 degree. In this, the angle guide is different. This is a 90 to 95 degree. The long barrel and the short barrel are different, and depending on the size of the lag screw of the DHS which you are using, you will decide that you are going to use a long barrel or a short barrel. All right. So if you are using a size of the 85 mm or more, then size of the lag screw, then you usually use a long barrel. And if you are using a screw, DHS screw of size less than 85, then you use a short barrel plate. And the reason for that is because you want a controlled cancellous collapse. That is the principle commonly asked for the DHS. What is the principle on it works? This is a controlled cancellous collapse. So if the distance, I'm going to show in the next diagram why we are using a long and the short barrel plate. And the barrel diameter is 12.6 mm. All right. So the diameter of the barrel is 12.6 mm. So this is a triple reamer and this is a lag screw. So if you can see the lag screw has the threads and lag screw has a shaft. So this lag screw has shaft, and the threaded diameter of the lag screw is 12.5 mm and the shaft diameter is 8 mm. And this triple reamer is meant for three diameters, different diameters. So the one diameter is for the threads, the other diameter is for the shaft, and the third diameter is basically the second diameter is mainly for the barrel, and the third diameter is mainly for the junction, the barrel along with the junction of the barrel and the plate. All right. So this is how DHS is kept. So to understand here why we use a long barrel and short barrel, you can understand that this is a plain shaft area which is a 8 mm in diameter. So this area will decide the controlled cancellous area or the controlled cancellous collapse which will happen after applying the DHS. So to achieve a controlled cancellous collapse, you should have at least 25 mm of this area empty. So if you have a screw of 85 mm, so you reduce this 85 mm, 25 mm here, all right, for this, and that 22 mm of this thread length. So this come a long barrel length of 38 mm. So if you are using a 85 mm screw length, so you can use a long barrel. But if you are using lower than that, then you should have a short barrel plate, all right. So this is how it looks like a DHS plate, because this angle is 135. Don't tell this plate as a DHS, because this is a dynamic condylar screw barrel plate. This is a DCS plate and commonly kept in the exam to confuse the student. So check this, that this angle is 95 degree, 90 to 95 degree, not 135 degree. All right. So this actually it was invented for distal femur, but commonly used in the intertrochanteric fracture femur also. These are some old nails or plates which can be asked, like a Smith-Peterson nail put along with this plate. Old plates can be kept in the examination but not asked too many questions about it, just identify. This is angle plate, commonly used if you are doing a valgus osteotomy for fracture neck of femur. So you should know its uses, how it can be used, and how it converts the normal fracture principles of the valgus osteotomy for fracture neck of femur. So this is different types of angle plate and how it looks from the end-on view and how the side views and different types of the plates. All right, this is a top view, this is a side view. So coming to some OSCE exams, as I've already told you, OSCE question for the implant is identify uses, principles, and the benefits. So you usually ask these kind of exams in the OSCE. So identify the implant, what are the uses, what is the principle of this implant, and what are the benefits over the other implants. So you will be shown 1 or 2 implants. And this implant Viva can be combined with the X-ray also. All right. So I have covered all the questions. I am going to not again show you the implant. I am going to show you some X-rays of 1 or 2 X-rays for the plate, and then we will move to nails completely and finish up in 10 minutes. All right. So this is the plate. For example, you will be asked identify the plate and the phenomena. So if you can appreciate that we have removed some plate here, and you can appreciate the cortex is completely damaged. All right. So this is a screw holes and the cortex is completely resolved. So what kind of plate it can be? It is a dynamic compression plate which was earlier applied to this patient. So just a viewpoint. So you, by just seeing the X-ray, you can identify, oh, must be a dynamic compression plate, because I am seeing lots of resorption of the plate or resorption of the bone beneath the plate. All right. Then identify this kind of plate. So you can appreciate that there is some trapezoidal grooves beneath the plate. If you can appreciate, so you can say that this is a LCDCP, and benefits you can tell as I've already told you. So this is LCDCP. You can appreciate this plate from the X-ray. There is cutting beneath the plate under surface. So this was the plate which was applied. Identify the plate and the mechanism. The plate is a T plate. All right. The mechanism, the principle is a buttress plate. All right. So we have applied in the buttress manner. Identify the plate and the principle. Again, a compression principle is used, and you can identify that, okay, this is a LCDCP was used. All right. Then identify a plate. This is an anatomically recontoured plate of the philos, proximal humerus locking plate system. And then you can be asked with this plate that identify the screw also. So if you can identify in the X-ray that this screw is a cortical screw, the core diameter and the threads are quite large than the core diameter, and the pitch is quite high. And if you compare this screw with this screw, the threads are not visible, separate from the core diameter. The pitch is not visible, and you can say in the exam, okay, sir, we are dealing with the locking screw. This is a locking screw, and this is a cortical screw. All right. So this is above one is a cortical, and this is a locking screw. So we can skip the history of the nails and come.
Amit, just hold on.
Yes, sir.
I think we'll definitely give you a breather. I think this was an amazing monologue on screws and plates, and very impressive. And as we had discussed that we might take any questions from the audience if there are any. Are there any questions from the audience, Ravi, or if there are any comments from?
Not yet, sir.
Not yet.
Sir, I want to ask one thing, Dr. Amit. While putting the plate over the forearm, you should tell something why we should bend the plate. Because there is a concept, otherwise, without bending the far side of the fracture may open up.
Principle of pre-bending.
Yes, sir. Definitely, because as you can see that already it's the principles are already too much, and in 1 hour I could able to only complete the screw and plate. So the principle of pre-bending is, yes, sir. Can I reopen my slide? Just to tell the audience with the help of this.
By most of the time, this question is asked to all the students.
Yes, sir. Although not very beautifully shown in this diagram, but let me tell you why pre-bending is required. Why pre-bending is required? Because if you don't pre-bend a plate, because most of the bones in our body are eccentrically loaded. And what do you mean by eccentrically loaded bone is that it has a curve in the bone. And curve in the bone means that it has a convex surface and a concave surface. And usually when it breaks, the tensile surface of the fracture takes the bone away. So if you don't pre-bend the plate and apply the plate straight like this, although this is a pre-bent plate already, so what happens, as soon as you apply the screw here, so the near cortex to the plate, because you are just visualizing your near cortex. You are just visualizing the near cortex, not the far cortex. So the screw pulls the whole of the bone towards it and attaches the plate to the bone. And as soon as it attaches the bone to the bone and applies compression at the fracture site, the far cortex opens up a bit. But when you pre-bend the plate, so what happens is your plate becomes a bit short with respect to the bone. So when you pre-bend the plate, so if you can see, this pre-bend plate is a shorter in size in comparison to the normal span of the bone which it wants to cover. So when you try to put the screws in a pre-bent plate, then this pre-bend, the two principles will work. The one principle is that the forces of the pre-bent plate will compresses the far cortex of the bone and don't let it open up. So this is how it is beautifully shown when you are pre-bending the plate, and when you are providing the screw, then the near as well as the far cortex compresses. But if you are not pre-bending the plate, then the far cortex will open up, because as soon as you put the screw and achieve the compression, the plate and the screws, pulls the bone towards it and opens up the far cortex. And another principle which I highlights in the presentation, that if you are putting, this is a common mistake done by the students also during the surgery, that what they does, that they put the far screw, they pre-bend the plate, but they put the far screws first and then they put the near screws. Then what happens is, then again occurs the problem? What occurs the problem? As I've already told you that the plate span is shorter than the bone span when you pre-bend the plate. And if you are fixing the plate distally first or the distally or proximally, and then you are putting the near screws, then what will happen is to accommodate the plate, the near cortex will distract. So this is another issue. So you have to pre-bend the plate to avoid the far cortex distraction, and then after pre-bending, you have to put the near screws first. I hope I have answered
yes.
correctly.
Yes, sir. Wonderful explanation.
So, Amit, another question which is asked is how much to pre-bend?
All right. So it is said that usually the bone which you are dealing with, the curvature of the bone which you are dealing with, so the curvature of the bone, 1/4 of that curvature you have to bend. So, for example, the curvature of the radius, definitely you are not going to examine it or beforehand on the X-ray, but by and large with the practice, you can get, okay, that this much of the bending is around to cover that curvature of the bone. So the curvature, the radius of the curvature of the bone, it is said that around 1/4 to 1/3 of that curvature of the pre-bending is required by and large. But definitely you cannot measure it on table. That comes with the experience.
So there are no correct answers to this question actually. There are certain working rules which people have passed on as our teachers, and they say that the size of the drill bit which you're going to use for that particular plate, the plate should be pre-bent that much. Meaning that if you place the plate flat on the table, then the same drill bit which you're going to use should be able to pass under the plate. So that limits you from overbending and lesser bending. Just a rule of thumb which has been passed over generations. Dr. Anup, your comments, please.
I think very exhaustive talk. Dr. Amit has covered each and every point regarding screws and plates. And most of the student gets all those principles wrong. And this is very, very important in all specimen Viva. I think wonderfully covered. Everything has been covered in his talk.
Dr. Sandeep?
I think most of the things he has covered. Just the tension band principle. How can a plate be put in a tension band principle? That is also a thing. But anyways, I think everything has been covered in detail. Nothing else can be asked from a PG student other than this. So
there are so many facts and figures in this topic that the PGs have to actually revise this, do it again and again. And if they think that this topic they're going to cover 1 month before the exam, it's going to be very, very monumental. Dr. Sharad, your comments, sir?
Yes, a couple of things, Dr. Amit. Exhaustive talk. I must congratulate you. The amount of effort you put in. Regarding the 4.5 screws, the core, normally we use a drill of 3.2 for all these, whether they are cortical screws or they are malleolar screws. See, the core cannot be more than that. Core cannot be 3.5. Core has to be less than that, about 3 or 3.1 at the most.
Yes, sir. Yes, sir. So the core diameter of the different screws, a bit, as I've already told you that like in a malleolar screw, the core diameter is 3.5. So the core diameter of a different manufacturers, I have gone through the different manufacturers also, and I found 2 or 3 odd manufacturers who are making the 3.5 also. And the reason for that I found is that in few literature it says that if you are putting a drill bit of around 90% of the core diameter also, it works good. Even few literature says that to the core diameter you should try to put a 80% of the core diameter of the drill bit size, so that you could able to put a very good screw. So there are different principles, yes, but you are right that the maximum core diameter in 90% of the screws or 95% of the manufacturer is 3 to 3.2 mm. There are one or odd diameter companies which are making 3.5 core diameter screw. So just told that, thanks for clarifying.
Then they must be advocating larger size of bit also. Then they'd be advising 3.5 mm bit, not 3.2 mm bit.
Yes, sir, you are right. Yes, sir, you are right, because as mentioned rightly that we are trying to use a drill bit of 3.2 with a 3.2 only, not a 3.5 with a 3.2. So they are giving a larger diameter drill bits. They are not giving a 3.2 diameter drill bits. They are giving a larger diameter drill bit.
Yes, yes,
Can I comment on this, Dr. Amit?
Yes, sir.
Actually, at two places, it is very important to have the core diameter correct. If you look at the self-tapping screw, it's very important to have the core diameter and the shaft diameter equal. Otherwise, you're going to have a problem in cortical screw. Yes, as you said that manufacturer are doing 80%, 90%, and it is being said that even with the 80% or 90% of the core diameter drill bit, you can work out. That is good for the cancellous screw, but not true for cortical screw. And that is where standardization of implant is very important. So by concept, it has to be same, especially you have a self-tapping screw. By concept, you can have a lesser diameter for cancellous screws.
Yeah, I think that's a very important point, sir, you have highlighted. And I think by mistakenly, the conventionally 3.2 mm core diameter, I think in my slide I have written 3.5. So to correct it, it was 3.2, but few manufacturers are making it 3.5. So to rectify it, thank you, sir.
Since the AO the advises 3 mm screw size, core diameter is 3.
Core diameter is 3 and the drill bit diameter is 3.2.
Yes.
3.2.
That's
yes,
the
sir.
standard.
That's the AO. That's the standard. That's what I shown in the slide later. That 3 is the normal standard diameter of the core, and then you are using a 3.2. But there are different manufacturers also, as told correctly by Dr. Anu.
Secondly, about the using a tap in a cancellous screw. I mean, even our practical experience is also there. At times, too, we have to use it to make initial partial entry.
Make the cortical breach. Yes, I understand. Yes. I could able to. I was thinking to tell the students, but as you know already the exhaustive lecture. So because the cortex, the cork screw tip of the cancellous screw usually is not able to pierce the cortex. So usually it is a convention that you use a tap to make a break in the cortex, and then you make the passage of the cancellous screw by the screw itself, as rightly mentioned by Dr. Sharad.
In fact, in the Synthes or AO screw box, in the screw instrumentation box, there is a cancellous tap separately given for cancellous screws, if you've seen, because at times if the bone is hard, maybe in very young patients and something, you will need to tap a little more than just to start.
Yes, sir.
The cancellous tap has also been given.
Yes, sir. But nowadays, conventionally, even the AO people are saying that the tap should not be used for the cancellous screw most of the time. The reason for that is if you are using a tap with a cancellous screw, it reduces the pull-out strength of the screw. So they have made it earlier for the harder bones. But if you are using a tap for cancellous screw all along the bone, then it will reduce the pull-out strength. So the conventional principle is that, but as mentioned rightly, that if you are dealing with a very hard bone and you are finding it difficult during the surgery, you can tap it, definitely.
And specifically in DHS screw, when you're putting the head screw, lag screw, it is always recommended to do a tap till the end. Otherwise, you cause rotation and you're not able to even enter at times to the desired depth.
Definitely, sir. But because DHS, I want to highlight again, because DHS, it is not all along, the threads are not all along, first thing. The second thing is, in between there is a shaft also. The second thing is that you are dealing with subchondral area of the bone also, which is quite hard. So all of the rotation occurs at the subchondral area. So as mentioned rightly by you, sir, that tap is definitely helpful if you are dealing in the DHS with a younger patient. But in older patient, we usually avoid to use tap because again it loosens up our lag screw.
Right.
Actually, here also there is a little bit of change of concept. As Dr. Amit, you said that now AO people do not recommend tapping in cancellous bone. You have to see fully threaded cancellous and partially threaded cancellous. That is quite true for partially threaded cancellous screw. If you're tapping the whole along, the pull-out strength it decreases. But for the fully threaded, it does not hold true. And the second concept, which had been discussed quite oftenly, that why in cancellous bone you do not have to have an tapping, is because the cancellous bone, when you're tapping, it's not actually removing the bone. It's just compressing the bone all along. So that is why you can get away in 4.5 or 4 mm screws without an tapping. But for any 6.5 or 7 mm screw, which are almost always a partially threaded, still you would be required to have a tapping.
Yes, sir. Thanks for this excellent description of these screws. Elaborate description. Definitely, sir.
So different manufacturers at times have some subtle variations. Like a cannulated 7 mm screw of Zimmer has a 3.2 mm guide wire, which is one of the thickest available in the market. And the AO has a slightly different. And if you go for a local manufacturer, it will be a third different. And in such scenarios, probably using the same company's system, that is a guide wire drill bit, almost becomes mandatory. And there are a lot of other concepts probably attached to the screw itself, like the metallurgy and what happens to the by increasing the cannulation diameter, what happens with decreasing the wall thickness, and various other concepts. Anything else, Dr. Manish, you would like to add?
No, I think everything is covered, but actually, unfortunately, I have not received any questions from the audience.
They are mesmerized with the bombardment of the persistent knowledge. I should really.
But it was a very elaborate presentation, and I should. Yes, and I congratulate both the speakers. Excellent presentation. Excellent.
And the photography of the screws was amazing. It's very difficult to take pictures of a screw to show the details, and there was no glare, and the details were very well appreciated. So if the house agrees, do we move with the nail? It might take another 1 hour if you have the gas to tolerate. Dr. Anup, Dr. Hariom, Dr. Sharad?
Yes, I think we can go ahead. Request to make it a bit comprehensive.
Actually, for the PG, we have to draw some line. Otherwise, these are all practical points which we are discussing. We have to draw a line for the PG students. So,
okay, Amit,
go ahead.
All yours. Share your slides.
Okay, thank you, sir. I will try to finish up in 15 minutes because nailing is not that, although concepts are there also, but I'll try to wind up in 10 to 15 minutes with that. As sir said that there should be lines, and I try to wind up as early as possible.
I hope you've taken a glass of water in between.
All right. So I'm just skipping the history part.
Maybe some history you can tell, especially about the K-nail, which is a favorite of all senior.
Sir, that will be taken up later also.
Okay.
So, yeah, this all history I can skip because this will not be asked in the examination nowadays. Okay. So, by and large, you can understand that the nails are divided into 3 parts, and then the nails evolve further. So, one of the nail is the centromedullary K-nail, which is the first generation nails. Then comes the cephalomedullary nails or the gamma nails, which are the Russell-Taylor nails, and then the PFN. And then there is a third type, which is a condylocephalic nails, which are the Ender's nail or the Lutece nail. So there are 3 types of nails which are commonly prevalent. Coming to the first, which is the condylocephalic nails. As the name suggests, condyles. These nails usually enter from the condylar area and then takes hold in the cephalic part. And then these are usually known as elastic stable intramedullary nailing system. Is a primary definitive fracture care in pediatric orthopedic fractures, usually at TENS, which I'm going to show the photographs later also. This method works by 3-point fixation or a bundle nailing system. The elasticity of this construct allows for ideal circumstances of micromotion for the rapid fracture healing. Coming to the non-reamed nails, so what do we understand by the non-reamed nails is that there is an intramedullary canal which is completely hollow. So you can increase the diameter of the nail by reaming that area and removing some of the some of the cancellous bone, so that you can increase the diameter of the nail. As we all know that the increased diameter of the nail will increase the torsional strength or the breaking strength of the nail. But the non-reamed nails are actually not the nails, but they are actually like the pins. Their mechanical characteristic and use are different from the IM nails. They are smaller in diameter and they are more elastic. Their flexibility basically allows the insertion through a cortical window, and there are many different types of flexible nails which are best known, like Lutece nail in tibia, rush pins for the long bones of the body, then the Anders nail, and there are lots of nails are also there. So coming to this intramedullary nails to be used as a single without reaming, one of these nails shown in the A is a Snyder nail, solid four fluted cross section and self-broaching ends. Not kept in the examination, just for the historical purpose. Even all the three nails are for the historical purpose. Nowadays, these are not used and just kept for the historical purpose. So you can just grab these names if they are asked, okay, tell us some intramedullary nails apart from which are not reamed nails, all right? Coming to this, which can be kept in the examination, like the rush nail. So this is a rush nail like a hockey stick, and a sharp end at the one end is a sharp and the other is a hockey stick kind of thing. Solid, circular in cross section, straight with a sharp beveled tip and a hook at the driving end. So definitely you can know that for the long bones it can be used rush nails, and these are the Anders nail. Anders nail, which are solid pins with an oblique tip and an eye in the flange at the other end. So if you can see these flange is a broader area and it has an eye. And these are the solid pins, and this has a sharp end. They were originally designed for percutaneous close treatment of extracapsular hip fractures. All right. So if you are dealing with the Anders nail and you are shown such kind of nail with a tip here, and there is a flange here like a broader flat surface with an eye. So this is a Anders nail. All right. So biomechanics of this 3-point fixation principle is like in the tense nail, each nail is pre-curved to achieve 3-point fixation where the required pre-curve should be approximately 3 times the diameter of the long bone at its narrower point. So what it means is, for example, this femur diameter is around 40 mm or 36 mm. So the curvature of this nail should be 3 times of that diameter. So if you are checking for the curvature at the proximal and the distal end and in between the middle point, so it should be around 12 centimeter. All right. So a part of the biomechanical stability is provided by the intact muscle envelope surrounding the bone, and you have the 3 bony point fixation, one at the entry point, one at the tighter area, the isthmus part, or the part where the curvature ends and the curvature in the other side starts at the fracture site, and the third is in the proximal metaphyseal area. All currently available nails have beaked or hooked ends to allow satisfactory sliding down on insertion along the inner surface of the diaphysis without impacting the opposite cortex. So there are 2 basic methods of the intramedullary pinning, and which are, one is a 3-point compression. So 3-point compression I have already covered, that you have at the site of the fracture, at the proximal point or the distal point from where you are entering the nail, and at the third point, the distal part where the curvature is ending. Most pin stabilizes the fracture by 3-point compression, and these pins are C or S shaped and they act like a spring. So you make it a curve, and as soon as they enter the bone, that recoiling effect of these elastic nail basically maintains the reduction, and it maintains that permanent forces which will maintain the reduction. So the equilibrium between the tensioned pin and the bone with its attached soft tissue will hold the alignment. The principle of bundle nailing was introduced by Hackethel. He inserted many pins into the bone until they jammed within the medullary cavity to provide the compression between the nails and the bone. So this is known as jammed nailing. Both techniques should be seen more as IM splinting than rigid fixation. So these are more like splints. Like for example, you are dealing with an open fracture, or you are dealing with a principle in which you don't want to reduce the bone, or you are in the periphery, you don't have C-arms to do intramedullary nailing, you don't want to open the fracture also. So by minimal opening or something like that, you don't want to use a C-arm, you use these techniques. Both techniques should be seen more as IM splinting than a rigid fixation. They don't provide rigid fixation, they just provide some sort of splintage. Bending movements are neutralized, but telescoping and rotational torsions are not prevented with this technique. All right. So this is a
We lost his contact.
Even the slide is not moving.
I think some problem with the electricity, because power failure causes this, and then or we can Lalit, you can discuss till he is back.
His battery must have gone off.
Maybe something like that. So we can have discussion. You can start the discussion.
So anything else on plates and screws? I'm not sure. Did he touch about the various functions of plates and screws, Sandeep? The neutralization function and all those?
Yeah, I think even the nailing part, I think he's talking about the tense nailing and the flower vase effect, the 3-point direction, that is also important. And regarding the plating, yes, the neutralization plate and the pre-bend concept he has explained, but the neutralization needs to be that where the plate just is used as a neutralizing device. So we can use the lag screws to reduce the fracture, and then on top of that the plates are applied just in a neutralizing mode. So I think that was not touched. That is the only thing I think.
Dr. Sandeep, is there any difference between neutralization and bridging plate?
Yeah, neutralizing plate is when you have already fixed the fracture by a lag screw or something. So fracture is not going to move. So on top of that, once you have fixed it, the whole work is being done by the lag screws rather than the plate. So it is just neutralizing it.
And can you describe about the bridging plate, because for the benefit of
plate is just like a MIPO. Means where you are not opening the fracture and you are just bridging the fracture, and where the working length is quite large. So if the working length will be large, there will be some micro motion at the fracture side and the healing will be better and faster.
Yeah.
Basically is how you transfer the force which are coming onto the fracture. In bridging plate, the force are transferred to a longer span, while in neutralization plate, the force on the screw which is being placed to reduce and fix the fracture is being partially transferred to the plate. So the plate or screw, they are not the sole implant which are taking the whole of the force. That is why it is called neutralization plate.
Another point regarding neutralization plate isn't that like you have to put in a screw as an interfragmentary as a device, then you want to protect the bone from rotational forces and other forces. So the neutralization plate is going to protect you from those forces which is not being covered, they are controlled adequately by the screw.
Very true, sir.
Regarding since we are discussing plates, regarding the concept which we were discussing regarding pre-bending the plate, when we want to avoid distraction at the far cortex, don't you think it is what we do is we pre-bend the plate and then start putting screw from the edges, not from the center? Then only you will get a compression at the far cortex. I mean, that's what the images which Dr. Amit was showing also show the same thing. But in description,
there is a experiment. This may be personal experimental.
There's a for and against for both, actually. There are people who have shown that if you fix the faraway screws, there would be a subtle opening on the near cortex. So, and even otherwise, whenever we talk about the compression in a DCP, invariably we put the screws which are closest to the fracture area. So there is a unsolved debate on this concept. Since most of us are using the eccentrically loaded screw also, so we tend to put the screw earlier in the nearer to the fracture area.
As a routine, yes, we do.
Yeah. So Amit, Manish was right. The light has tripped and he's connecting back shortly. So another common question which is asked is what are the functions of a plate? Meaning a same plate can be used in how many roles? As rightly suggested right now, bridging could be one role, and your neutralization could be one role. And Sandeep had did mention that earlier, that it could be a tension band plate, that could be another role. And then there could be those buttress and the anti-glide roles. So this is one question which is asked, and the student should know that each plate can be applied in various different type of roles. Any other tricky questions up your sleeve, Dr. Hariom or Dr. Anup?
Sir, I want to ask one thing.
Yeah.
That most of the time this is being said that while putting screws in the plate, put one screw in the centric mode and another screw on the other side of the fracture in the eccentric mode. This is usually advocated. But some people are putting both the screws in the eccentric mode. They are not fully tightening it. Then they are putting two screwdrivers on the each screw. Then they are gradually tightening it to give complete compression of the fracture side. What do you say about this thing? Putting both the screws in the eccentric mode, then tightening them together by two different screw holders drivers.
Like that? Ravi, probably Amit needs to be entered into the group.
Yeah, I've entered him.
So, he's in, sir. He's in, sir.
So Amit is back and he's in a different color now. That's great.
Actually,
glass of water or pack of
actually, sir, I need to shift down to first floor because my floor internet goes. That is a problem of online issues. So
Dr. Hariom had asked a question. I'm just addressing that question.
Yes,
people use various types of modifications in getting their compressions, and it's a concept of Dil Mange More. They want to have more and more compression. So there is a concept in the AO manual in which it is said that you fix the central screw and then go on the eccentric side, and it is very clearly said that you can go only up to 2 screws on the eccentric side, and that's the maximum that you can get. But then you have various type of local implants and various types of concepts in which people try to sort of indigenize because things don't work at times in their centers, and they find in their own experience what works, so they modify the techniques a bit.
Yes, sir.
I hope Amit is back now with his PPT.
yes, sir.
Kindly share your presentation.
So this is rush pin which we were dealing initially. All right. So this is a rush pin. Sorry, rush nail. Yeah. So I think we can skip this part, but it is initially used for the Monteggia fracture. Rush usually used to manage the Monteggia fracture with the Specimen pin, and then he developed the rush rod for that. So now coming to the most important part, which Dr. Manny was discussing, that is a K-nail. So K-nail is one of the favorite question for the examiners, because in earlier times K-nail was used quite commonly. If you can identify these structures, so this is a nail. There is a slot in the nail on one end, there is an eye on the other end, and it has a clover leaf model. All right. So this clover leaf model, apart from providing a 3-point bony fixation, like as I've already mentioned, it provides 3-point bony fixation in a axial plane also. So once this nail coils and enters the bone, and as it recoils, so this three bony points, 1, 2, and 3, they gives additional fixation to this nailing system. Coming to Kuncha's nail, so this is Kunchas basically presented a paper on intramedullary nailing in 1940. He practiced close nailing. During the World War II, he was on the Eastern Front. Knowledge of his nailing came to the Alice, and they mocked the infected cases. So reports were few until the Time magazine 1942 came out with a story of soldiers returning with a cane nail and no cast. Soon many surgeons produced their own pattern. However, a damning article from the Watson Jones held back further development for 20 years. He did the same for hemiarthroplasty till he himself needed one for the subcapital fracture. So this is a picture of Kuncha's nail, and on view, this is an eye. There is an eye on both the sides. This is a slot. You can appreciate this slot, empty slot. Now, what are the OSCE related questions for canal? So first of all, you will be given the canal and you will be asked identify. And you will identify, okay, this is a canal. You will ask what is the full form of canal. Then you will say, okay, the canal is Kuncha's nail. And even people can ask the spelling also.
Yes,
the examiners.
Yes, sir. Yes, sir.
Kuncha's nail, because the students can get confused with the Kushner wire and Kuncha's nail.
Yes, yes, yes.
Then the question started, which side Kuncha's nail is this? So the first answer, usually the students, because they are not using Kuncha's nail commonly, so they said right side or left side. So the Kuncha's nail does not belong to any side. All right. Then the next question of the examiner is, why the eye is at two end? Why the eye is at two end? Because first question is, why there is an eye? So the answer is, the eye is there because if the nail gets stuck, so you can apply a hook here and you can take out the nail. Then the examiner asks, okay, so you want to insert a hook here to rake out the canal, then why the eye is at the two sides? And then the student usually stuck, because he should know that during the World War also, and in the initial days when there was no Siam, we used to do retrograde nailing. And when you are inserting the nail from the fracture side, so you are keeping one eye at the inside of the bone, because that will exit the piriformis fossa and later it will be used to take out the nail. And the one eye will be in the hand of the surgeon, that while during the insertion, if it is stuck, so he can apply the hook here and take out the canal. So these are the two uses of the two slots, commonly asked question. So why the eye is at the two end? Then the next question is, where is the slot? That means the slot where you are going to put the slot. So it is said that the slot, the eye is opposite to the slot, and it is said that the slot, when it is put on the tensile surface of the femur bone, then it will produce the maximum strength to the nail. So the slot is kept on the anterolateral aspect of the femur. So definitely the opposite side will be the eye, that is the posteromedial aspect will be the eye. All right. Then the next question is, reaming till what size? So commonly the students are doing interlocking nails nowadays, and when we are putting a 11 size of nail, usually we ream till 12 or 12.5 in a conventional interlocking nails nowadays. But in K-nailing, usually we ream till the size of the K-nail which we are going to use, because we want it to expand inside the bone. So we want to compress it and then expand it. All right. So the size of the reaming is usually the size of the nail which we are going to use, because we want that expansile elasticity of clover leaf model to give additional compression, additional stability. How to calculate the size or the length of the bone, length of the nail? So conventionally we usually take the length from the GT tip to the superior border of the patella in interlocking nail. Nowadays we add 2 inches to the K-nail so that we can remove the K-nail easily, so that the eye of the nail will be out of the piriformis fossa for easy extraction of the nail. So you have to add 2 inches to the nail size, and you are going to calculate the nail size from the GT tip to the superior border of the patella from the normal limb. Coming from if you have the bilateral shaft of femur fracture, then the common convention is that you are going to calculate the size of the nail from the olecranon tip to the tip of the little finger of the forearm. Forearm olecranon tip to the little finger tip, and then you add again 2 inches to it to calculate the size of K-nail. But the size of interlocking nail you are not going to add the 2 inches. All right. Then the last question is usually, what is the ideal indication in the current scenario? Because now K-nail is not used. So the side effect of the K-nail has already been discussed with you people, that K-nail provides the good stability in the bending strength, bending torsional forces, but for the rotational forces and the telescoping forces, it usually does not provide much stability. So it has been seen that the fractures which are in the distal femur or even in the mid-shaft femur, they are going into the non-union because it is not providing the rotational stability. So we have moved further to the interlocking nails, which the students are nowadays seeing day-to-day life. So the ideal indication in the current scenario is a transverse fracture in a young male at the isthmus, because the isthmus is the tightest area, the smallest, narrowest area of the shaft of the femur, and you can use that in the shaft of the femur, and because it is a tight, so it will give a tight fit, and the clover leaf mechanism will provide some rotational stability to that type of fracture in a good manner. Otherwise, all other fractures, the rotational stability will not be there. So the current days, the ideal indication is not there. The only ideal indication is a young male transverse fracture in a isthmus area. All right. So these are the questions which are usually, these are sequence of the question which are usually asked. Maybe I have missed, and seniors will guide in the later discussion for the K-nail questions. And this is a K-nail extractor and the hook which I'm talking about, which will be used, and this threads will engage in this hook, and this hook will be engaged in the eye to extract the K-nail. So this is a K-nail extractor, and this was a hook. This is a guide wire or perforator to perforate the canal if you are using an antegrade manner K-nail, but usually earlier days it was used in the retrograde manner only. And this is the K-nail diameter measuring gauze. All right. Coming to these kind of nails, which are different types of nail, which are known as square nail. The nails are usually described, as I've already told you, these are the nails more commonly known as a pins, because they are mostly the non-reamed nails. K-nail is a reamed nail, but this is also not reamed regularly. We usually put it without any reaming. Now, this is a square in cross section, and being square in cross section, these are known as a square nail, commonly used in two bones, radius and ulna. So the top one is a radial nail and the lower one is the ulnar nail. You will be shown in the exam, and then you will be asked another question that, okay, how you are identifying this is a radius and this is a ulna. So although I tried to remove that glare kind of thing from the photo, but not successful, so I have highlighted this in the another photo. So from the back side, both the radius and the ulnar nail are same, but at the distal point, the radius has a radius of curvature kind of thing here and a sharp tip. Radius of curvature. So easy to remember. If you have this radius of curvature, this is a radius nail. And you have a sharp trocar kind of tip, then you are dealing with the ulnar nail. And then the other further questions will be asked that, okay, you are dealing with the ulnar nail, what is the entry point? So for ulnar nail, you are going to use from the olecranon. The entry point is from the olecranon. And for the radial nail, the entry point is from the Lister's tubercle distally, from the dorsal side. So you will be asked some complication also. So the complication will be again the same. First of all, they are not going to provide some rotational stability and all those things. That's why radius nail is not at all preferred nowadays, because in forearm, radius rotates over the ulna. So you may prefer ulnar nail in cases of some open fractures. You don't want to put a plate or something like that. Moreover, you want to put nails in the lower limb, because nails are a load sharing implant. They share the load with the body, with the bone. So you, because there is a lots of load on the lower limb, so you prefer nails over plate in the lower limb, and the micro motion of the fracture will give you a compression at the fracture site. But in the upper limb, you prefer plates over the nail, because you want to achieve compression at then and there only during the surgery. And still, if there is indication that you want to give some stability, and still you could not able to use plate because of open fracture or something like that, so radial nail is still not used, because radius rotates around the ulna, so you could not able to provide early mobilization. Moreover, radius produces wrist stiffness, Radial nail also leads to one of the tendon rupture in long-standing patient, that is a EPL, extensor pollicis longus, which gets ruptured because it gets turned around the listus tubercle, and because of over friction, repeated friction over the nail, it gets ruptured. So this is a complications of the radial nail, hence not used. Ulnar nail can be used nowadays also, especially in cases of open fracture. So this is a tense nail, titanium elastic nail system. Why it is made of titanium? It comes the next question. Because titanium modulus of elasticity is close to nail, no, close to bone. The stainless steel, the modulus of elasticity is quite high. The titanium has a modulus of elasticity quite low, which can bend easily, but it has good amount of stiffness also, equal to the stainless steel, even higher. So it is 1.6 times stiffer than the stainless steel, but the Young's modulus of elasticity is lower and matching with the bone. So it easily get bends, provides that elastic nature, gives that load sharing feature, and then that's why it is made up of titanium only, and that's why they are named titanium elastic nailing system. So they have something known as they have this bend. So don't get confused with this bend. This is not a hockey bend kind of thing which is there in the rush nail. So this is just a bend which makes it like a L, not exactly a hockey shape. A hockey shape maybe, but not exactly that stick, shepherd crook stick. All right, usually used in the pediatric femur fractures and which need surgery. So these are just the nails. They can be kept end on end for you in the exam, and then you will be asked, okay, keep taking one by one and telling one by one. So you take one by one and tell one by one. So that's why tense is kept along with rush pin, so that you can identify that these are two different things. Don't get confused. Tense nail are available from 1.5 mm to 3 or 3.5 mm in different diameters. Tense, how it works, I've already told you. It works on the 3-point fixation principle. Now comes this nail. These are the intramedullary nails. So we are moving to the next type of nail, which are intramedullary nails, which are interlocking nails. So intramedullary, one is reamed nail, which is a K nail. Then intramedullary locking nails. So you can see these holes inside the nail system, and these holes are basically to put that bolts, which I have shown you earlier, so that they can give additional rotational and telescoping stability to the fracture. All right. So these are additional screws. So this is a nail you can be given in the exam and will be asked, what is this type of nail? So this is a tibial nail. How you are going to identify? Because if you are seeing from the end on, from the lateral side, you have this kind of bend, and then whole of the nail is smooth. This bend will get you identify that this is a tibial nail, and this bend is commonly known as Harjok bend. And this bend will be asked, how much degree bend is this? This is a 11-degree bend. The bend angle is 11 degree, and this bend is basically to appreciate the structure of the proximal tibia. So if you see the lateral view of the proximal tibia, the metaphysis and the diaphysis has a bend. There is an angle between the metaphysis, the articular surface, and then the diaphysis. So to appreciate that bend, there is a bend made, and this bend is known as Harjok bend. And this is 11 degree. All right. So this is a nailing which we have used, and I hope you can appreciate, because this is the entry point. And the entry point is kept anteriorly to prevent the cartilage. So because we are a bit away from the direct line of the medullary canal, and entry point is anteriorly, we cannot enter from the direct midline, because ligaments are there, vital structures are there, cartilage is there, and we have to enter from the bare area, from the anteriorly. So to appreciate that bare area, the bend, this is a Harjok bend. All right. So this is a tibial nail. Now this is another nail which will be kept in the examination for you to identify. So please don't get confused with the tibial nail. Don't get confused with this nail with the femur nail. So you can see there is no sharp bend here. The screws are only on the one surface. If you compare with the tibial nail, even in the expert tibial nail, this is the expert tibial nail which has different direction screws also. But in a tibial nail, in a femur nail, the curvature is smooth. there is a anterior bowing to appreciate the anterior bowing of the femur. So don't get confused taking the femur nail and saying this is a tibial nail. This is a smoother bend, and this is basically to appreciate the anterior curvature of the femur. So this is a femur nail. All right. Now, you can be asked after giving the femur nail, okay, tell us how you are going to make an entry point. So the conventional femur nails which we are going to use is a nail from the piriformis fossa, and piriformis fossa is usually a bit posterior from the anterior aspect. So over reaming the entry hole by 0.5 to 1 mm, selecting the entry point posterior to the central axis reduces the hoop stresses. So it says, there are researches which says that if you are making the hole here, even a 6 mm anterior to the conventional hole place, then there are large hoop stresses, and during the reaming, you can land up into a fracture of the proximal GT or something like that. Those mishappenings you can avoid by making the this kind of entry point perfect. And this kind of entry point is posterior to this central axis. All right. So this is the ideal entry point. Now you will be asked this kind of nails also in the exam. You will be given this kind of nail. So this is definitely an intramedullary locking nail. But this intramedullary locking nail, if you see, so the previous intramedullary laying, I have shown you a lateral view from the side view. Now I have shown you a straight view. So this is a proximal femoral nail on the right side. What is the difference from the normal femur nail? Normal femur nail, as we know, that the piriformis fossa is exactly straight to the intramedullary canal. So the nail from the, if you are looking from the straight away, so you can see that there are no screws visible. So the earlier view was from the side. This is from the top. So the femur nail will be exactly straight, but the PFN will have a slight bend, and this bend is around 6 degrees. And why this bend is made? Because proximal femur nailing is the entry point is not the piriformis fossa, the entry point is greater trochanter. So these are GT entry nails. All right. So this has a bend, and the proximal femoral nailing, because they have a bend, so they become side specific also. All right. Then these are commonly classified under the gamma nails, and after classifying under the gamma nails, and these are advances. So this is a kind of PFN which is advanced version of PFN. So you can see this is a straight rod coming. But then if you continue this line, this will go this way. So there is a bend. This bend is again showing that you are dealing with some kind of PFN, but the screw hole is single, and there is a blade which is different from these screws or bolts. So this is known as proximal femoral nailing A2, PFN A2. All right. So there is a PFN A, first comes in the market with a helical blade, and this blade is different from the screws because this has a different torsional strength, and these are commonly used in the osteoporotic fractures, commonly a thicker screw. And then you will be asked about the benefits of these nails and usage of these nails. So these nails, because they get hold in the femoral head, as you can appreciate that this is a nail going in the femur and you are taking purchase in the femoral head. So these are the nails which will be used in intertrochanteric fractures and subtrochanteric fractures. All right. Coming to the OSCE, so this is just identification. Then we are going through some questions, how you will be asked in the Viva. So this can be the X-ray given to you and will be asked along with the nail that, okay, identify what is the type of nail. I hope everyone listening to this talk can identify, okay, this is a tense nail, titanium elastic nailing system used in the pediatric fracture femur. Can tell pediatric fracture femur because there is a epiphysis in the X-ray. And then you can tell the curvature, how you will decide the curvature. Then you can tell the 3 bony point system. Then you can tell why they are made out of titanium, the full form of it. And your Viva ends there for asking 4 or 5 questions. Then you will be asked showing this X-ray or a nail. Okay, tell us what is this type of nail. So saying intramedullary interlocking nail, and you have to take cell piriformis entry nail. So just an intramedullary interlocking nail will not be sufficient. So you can see that interlocking nail, there are 2 screws kept superiorly, and there are 2 screws kept distally. I will show the X-ray later also. And then I have already discussed about the entry point. It has to be a bit posterior from the central axis. And a commonly asked question also, few examiners used to ask that if you are just checking on the AP view, how you are going to examine that your the awl instrument which is used for interlocking nail is perfectly in the piriformis fossa. So the commonly asked question, the answer is, it is given in your books also, that if you are viewing a C-arm in the AP view, then your piriformis fossa is having a normal pit, and the anterior centrum is a bit proximal shadow than the pit of the piriformis fossa. So if you have just kept the awl in the piriformis fossa and you are taking a AP view, then without even entering the awl, the AP view will show you as if you have already entered the bone, because the overlying shadow of the anterior part of that area will give you a feel as if you have already entered, but you have not entered. So that is the right position where you have to make the entry point. This is what I want to mention here. So I have not entered by this time. I have not at all entered, but I have just kept my awl in the right position, and you can see the cortex shadow. It appears as if I have entered, but I have not entered. I have kept the awl on the right position. So AP view you can identify like this. These are some major corrections we can skip. These are some surgical steps, and there is no end to it. So we can check that how you are going to do a good nailing, which is a altogether different topic. So we can skip it. But this is one of the photograph I have taken in my OT, that I use a shoulder bolster to make this angle, which AO described, that there should be a 10 to 15 degree of angle between the femur and the body. So I try to use this to make my entry point correct. And then there are various questions will be asked, like nail length. I have already covered that nail length should be sufficient till the superior pole of the patella, and just exiting just till the piriformis fossa, not longer than that. Just you can engage your nail removal set. All right. Then nail diameter, definitely you should be engaging full of the isthmus. Though it should be tight enough. It should not be loose. Then coming to locking screws or the bolt, basically. So you will be asked how many bolts. So there are different concepts, 2, 1, 1, 2. But mainly you will be asked type of screws. So you will have to tell that we are using the bolt. We are using not screws. These are bolts. Number of screw. So there is a recent concept that you can put a screw, single screw only, if you have a fracture site on a longer side of the fracture. So if you are dealing with a fracture here and you have a shorter fracture, fragment here, so in the shorter fragment you put 2 screws, and in the longer fragment you can put 1 screw also. Although in this X-ray I have put 2 screws because although it is a conventional, but still the surgeon is afraid of putting 1 screw and he puts 2 screws. But by answer you can give this answer in the exam. Now, this is another common question which will be asked. You will be given a nail and a screw and will be asked where you are going to put a dynamic screw. So the answer of this question is that it is always away from the fracture site. So you are putting dynamic screw either in the proximal fragment or in the distal fragment, but it has to be away from the fracture site. All right. Size of the screw, I have already told you. This is another post-op X-ray. You will be asked what type of nail is this. So if you can see, this is a GT entry nail, trochanteric entry nail. The nail is from the trochanter entry, and trochanteric entry nail or the recon nails give us a freedom that if you can see there is some screw holes, shadow is there. You can put simultaneously 2 screws in the head. These nails are designed basically because earlier days we used to miss out some intertrochanteric fractures undisplaced. And those intertrochanteric undisplaced fractures were identified intraoperatively during the C-arm. So these kind of nails were made in which we can put simultaneously 2 screws in the head if we identify such kind of fractures. And these kind of nails usually give you a freedom to put a long screw, which is GT to LT screw. And this screw has been, there has been research which says that this screw gives more stability in comparison to the 2 transmedullary fixation. So people prefer a GT entry nail and then a GT to LT screw. Benefits of GT entry nail, you will be asked in the examination. It will reduce the soft tissue injury because you are a bit lateral, may avoid injury to the femoral head blood supply. We all know the importance of femoral head blood supply. Reduces the chance of femoral neck fracture because as you are making a hole in the piriformis fossa, in piriformis entry nail, the femoral neck fracture, there are high chances. Then there are a reduced fluoroscopy and operative time also, because GT entry nail, the entry point, making an entry point is easier comparatively to the piriformis entry nail, and there is a short learning curve. What is the cons of it? The cons of it is that there can be eccentric reaming because you are a bit lateral. Piriformis nail is a direct entry to the intramedullary nail. So there can be eccentric reaming. GT fracture can happen. And one of the most important cons is varus reduction. So varus reduction means if you are going through the GT entry and you are pushing hard, so if you are dealing with an intertrochanteric fracture or a subtrochanteric fracture with this nail, you may land up into a varus reduction at those fracture site because of that angulation of the fracture or of the nail, 6-degree angulation. All right, so these are the cons. And definitely, why should you rely on me? Because these are the articles which will show you that what are all the benefits of the GT entry nails. And you have to get a good entry point. And again, the good entry point is the GT flare. Where you are feeling the GT tip, you have to be medial to that, all right? Not at this here. The students usually do mistake that they enter from here and then their GT gets fractured and lateral wall gets blown out. So you have to be a bit medial to that, all right? Okay. So nail length, I have already discussed. So nail length, the appropriate nail length is till the superior pole of patella. But now the latest recommendation said that it is not the superior pole of patella. You can go till the physeal scar. Physeal scar. So if you are dealing with a distal fracture, you should take your nail till the physeal scar. If you are dealing with a sharp femur fracture, you may end up your nail till the superior pole of patella. But you are dealing with a distal fracture, you should take to the nail to the physeal scar. So, and definitely you should not be much proud, and you should end to the GT tip. Nail diameter, as I have already told you, it has to be snugly fitting at the isthmus. Then proximal screw, I have already told you GT to LT and why it is better, direction, size, and then distal screw number, size, because we are dealing in the distal fracture, then definitely we have to put 2 screws. The size is definitely, I have already told you, it should be good. And can you tell me the problem with the nails? So the problem with the nail in this case is a bit of eccentric position of the nail. Although the fracture reduction is good, but still the eccentric placement of the nail is there. Eccentric distal placement of the nail, which can even lead to a mal reduction of the fracture site. So you can be asked in the examination, okay, we have put a eccentric nail, or the nail is not entering into the right side. So, and distal femur fracture is there. So how you are going to deal with that? So your answer should be polar or blocking screw. So this should be your answer, and there are various concepts which can be asked in the examination, that how you are going to decide which side polar screw should be put, polar screw or the blocking screw. So there are various concepts. One of the concept is that towards the concave side of the fracture, you have to put the blocking screw, and in the smaller fragment. So if your fragment is smaller, is distal, then you should prefer to put a blocking screw in the smaller fragment on the concave side of the fracture. And if your fracture is proximal fracture like in the tibial fracture, and you are dealing with the sagittal plane problems, and it may lead to recurvatum or procurvatum at the fracture site, then you have to put a medial-lateral screws. And if you are dealing with the coronal plane problems, then you have to put anterior-posterior screws. So if you are dealing with the proximal deformities, then you are going to put screws in the proximal fragment. But this concave side concept is not very clear to the students. Then Hanna et al. Has given another concept, which is the acute angle concept. Although I have not drawn the diagram, I think I have forgot to draw the diagram here. That acute angle concept says when your angle is oblique, when your angle of the fracture is oblique, you can see my cursor. When your angle of fracture is oblique, you draw the angle like this, and you draw longitudinal axis of the bone. When you draw like that, there will be two acute angles which are made diagonally opposite, and there will be two obtuse angles which are made diagonally opposite. So Hanna et al. Said that do not get confused with the concave angle concept. You can just put your screw in the smaller fragment in the acute angle area. So whether you have to put a screw here or here, it will be decided by the fracture configuration, and the acute angle will be made by the linear axis you are going to place there. All right. So this is a diagnosis of subtrochanteric fracture. You can be asked like this, you will be asked like this, what is the post-op X-ray, and identify the implant. You can be asked about the size of the screws also. Nail type is definitely PFN, proximal femoral linking, conventional PFN. You will be asked then proximal screws, what is the size? There are two screws, what is the size? Then you have to tell this is a latest PFN which has a different screw size, 6.5 and the 11 mm. It total gives a 17.5 mm size. But the conventional PFN, which can be kept in the examination, will have a smaller screw of 6.2 mm or 6 mm and the larger screw of 8.2 mm. So mind it, students, that the conventional PFN earlier, or the local vendors which are giving you a conventional PFN, will have a diameter of 8.2 mm, not the 11 mm. This is the latest AO or the Smith and Nephew PFN, which gives you this kind of diameter. Now this is again a 65-year-old male, and you know the fracture is osteoporotic. You will be asked what will be your implant choice. You will definitely say PFN A2. And this is the X-ray of PFN-A2. You will be asked nail type, you will tell PFN-A. There is a marginal difference between PFN-A and PFN-A2, basically a design of the proximal femur nail design. There is a difference in that. So the screw cutting slot is a bit different in a PFN-A2, and a designing difference, not a much of a difference, PFN-A and PFN-A2. And then nail length, you will be the same nail length as we have already discussed. Then you will be asked about the proximal screw. Then this is a proximal screw, which is basically a helical blade. So you will not call it a proximal screw. This is known as helical blade. This is not usually screwed in the bone. This is usually hammered in the bone. It has a compression area here. And when your helical blade reaches to the optimal zone where you want to make it reach, that is a subchondral area 10 mm from your cartilage area, then you are going to achieve compression by tightening this middle area. So how you have to put it can be asked in the examination, how you are going to put it. So first you have to disengage and distract this area of in between, distract this area, ensure this. Then you have to hammer the helical blade, and then you have to, after hammering, when it reaches to the right place, then you have to achieve the 10 mm compression which is there. All right. So the larger surface area and the increased core diameter guarantees the maximum compaction and the optimal hold in the bone. And the diameter usually, again, I am going to tell you, it varies from the different vendor, but 11.7 mm to 13.5 mm is the common diameter of the helical blade. All right. So these are kind of nails, and then there are conventional new nails, and then it can be a long nail or it can be a short PFN. There are a hell lot of literature which is discussing which we should use a long PFN or a short PFN. Still the fight is going on. By and large, in osteoporotic fractures or old age, my personal preference is to use a long PFN, and in a younger patient we can go ahead with a shorter PFN also. And then there are humerus nails are also coming, and you can use also that, but they have some disadvantage of disrupting the cuff, rotator cuff. So by and large, in upper limb we use plates, and in lower limb we use nails. Thank you. Thank you for your patience list.
Wonderful, very wonderful talk by Dr. Sumit. Sorry, Amit. Quite elaborate, wonderful, exhaustive talk. I think every point has been clear to our PG students. Nothing to add in it.
Actually, we are lucky that we had only 2 lectures. Otherwise, I think it would have been midnight.
But both of these are very exhaustive lectures.
Very exhaustive. Very. I think they covered
Dr.
everything.
Amit, you have rightly pointed out the word page quite confused in the PG student. They cannot spell out the name. What is the meaning of the K nail or K wire?
Yes, sir.
Kirchner wire or Kuncher nail. Confusing.
Yes, sir.
Sir, please clarify one thing. You
Yes,
have
sir.
told while measuring the size of the interlocking nail, you have told that it should be measured from tip of the GT to superior pole of the patella and add 2 inches to it. We should add 2 inches to it or 2 centimeters to it.
2 centimeters.
2 centimeter. 2 centimeter. I think I have told mistakenly 2 inches. It is 2 centimeters.
2 centimeters.
Sorry.
Yes, yes.
Actually, I am also tired, I think, now today. It was an exhaustive talk, and now I feel that I am tired.
He can understand, Dr. Amit.
But it was really a wonderful talk. Wonderful.
I know it must have taken hours together to put up so many facts in PPT and making 190 slides. It's not an easy task. So wonderfully done, Amit. Really wonderfully.
Thank you, sir. Thank you, sir.
We will put this on YouTube. So I think will be an iconic lecture, so that any student going for exam, he can watch that. I think nobody can fail you in table Viva.
Regarding the canal, it's commonly asked that why there are 2 eyes on either side. This is the commonly asked question. You have answered each and everything which are commonly asked to the PG students.
One more question which is asked regarding to K-nail is that what is stack nailing? And it used to be done earlier. So if the diameter of the nail is not available and the nail is used, what will you do?
Yes, sir.
So usually what we used to do, we used to stack 2 nails and then put it in.
Put it in.
That is another question, very favorite question of the examiners then they ask. But nowadays, K-nail is not being done so much. So therefore, we don't answer.
Another question used to be loose nail. What if your K-nail is used? Give me 5 solutions to it.
Yes, sir. K-nail is loose, or if your K-nail is stuck, or any other nail is stuck and not coming out. So how to remove a nail is another Viva question, and you have lots of literature, and even Dr. Mani and other researchers and other seniors sitting here have published lots of data that how to remove a stuck nail if you are stuck. So definitely a worthwhile questions.
So another thing the PGs should go and read extensively is the pathoanatomy and pathophysiology of reaming. And there's lots written about reaming, and there's a lot of science behind development of reamers. That is another area which they should read up.
Yes, sir. Actually, I want to just add up that I have not put reamers here because in the exam I usually don't see reamers to be on the tables. So I have not kept here. So, but yes, definitely highlighted very rightly by Dr. Mani that they should go and read about this.
So, Dr. Sharad, your thoughts?
Yes, a couple of things. Is the Kuncher nail still relevant? I mean, anybody doing Kuncher nail so much that being asked in the exam at present even?
Yes, yes, of course. Kuncher nail is still asked. It is asked in the MBBS exam also, and because it's a hallmark question and a plant, and we at times do end up doing the Kuncher nail off and on once in a year in certain scenarios.
It's a poor man's nail when you want to finish surgery in 10 minutes. You just open the fracture, do the reverse nailing, and come out of it.
We were talking about the 2 keys, 2 eyes in that nail. I think the other reason could be that if the nail is gets broken, I mean, and the one party gets stuck in the distal fragment, then you can use the other eye to take it out with the hook or something. I mean, that's another use for having 2 eyes in the Kuncher nail.
Yes, sir. Definitely, this can be the answer.
Actually, the current generation of PGs might not know that the female nailing is done open also. So that itself might be news to them.
That once in a while, even now we open once we are not able to reduce it. I mean, that's not.
That's just a keyhole opening, but those classical open techniques of the approach and all that, most of them have not seen.
And a word about the expandable nails also means when we are talking about the nails, then I think that just the naming of it is to be done. That okay, this is also.
Yes, sir.
Then I think removal of the nail, that should be another topic we should be added. Whether we should go for removal of the nail or not. After some time, after 1.5 years or 2 years, whether we should go for the removal of the nail or let it be there only. This is another topic which need to be discussed.
Implant removals in orthopedics, why and when?
Yeah.
Yes, sir.
A whole topic.
Definitely.
Dr. Manish, are you still awake?
I'm awake. I have to be awake. I have to be awake.
So your thoughts, please.
I think it's an excellent, and I think I have already told it's an iconic lecture, and I will circulate this thing because it's very, very useful. And probably part 2 of the instruments are also remaining.
So I hope you have understood now. It will not be part 2. That part 2 will have A, B, C, and D parts also. You know that we have very good presentations and speakers and knowledge available. So if you can do them in a systematic way, it will be a very good archive.
Yeah, why not? Why not? We'll do it. And what are the comments of Dr. Anup Agarwal? He is our expert panelist. How did you find it, sir?
Yes. It's very useful, not only for delegates, even for us also. No, lot of concept, lot of things which has really come up, and it was a revision. No, the only suggestion to all my PGs is that keep all those K wires, different square nails together, and then see the difference actually physically before you're going for the examination. Because seeing the picture and actually seeing all the nails together makes a difference. And many a times when you have a physical examination, it is the bunch of nails which are the examiner keep and ask you to pick up an Steinman pin from this. And then you are confused. A 2.5 mm Steinman pin and you have a 2.5 mm K wire, then you're confused. So keep all this together, look, identify, see the features, and then do it. Probably you can do it. So it was, I think, wonderful. Both the talks were wonderful. And as Dr. Lalit Mani said, that really you need to plan it more and more lectures and divide it into so that a lot of discussion can come out of it. It doesn't become such a long, because any long lectures become boring after a certain time. No, your grasping power goes down. So we need to curtail it to some time restrictive lectures we need to keep. But anyway, wonderful, really wonderful.
And I think another point would be is to go to OT again and again, see those nails. I mean, it's very difficult to cram just once by seeing the picture. You have to go again and again to the theater, participate in the work there. Then you will get used to the nails, most of the things.
Definitely.
So I think we call it a day if you don't have any other comments, and Dr. Sharad to do the final comments and Thanksgiving.
Right. Thank you, Dr. Mani. Well, it was a wonderful and exhaustive session, and we touched the very basic things which make orthopedics and make orthopedic surgeons. Sincere thanks to Dr. Sumit Arora for those specimens and the OSCE questions and all which he took, and Dr. Amit for exhaustive 2 lectures, I would say, one on the plates and screws and another on the nails. I think, as Dr. Anup said, we all been benefited, we have been revised, and so many things we've been doing over the years, and we may have forgotten why we are doing them. So they got revised. And of course, the PGs would have learned a lot of things. Thanks to Dr. Anup and Dr. Hariom to be our guest today here, from sparing time and giving their valuable inputs. And as usual, Dr. Lalit Mani for managing all the show, and Dr. Sandeep for being one of the moderators. Thank you. And thanks to Dr. Manish Dhawan. He's looking already drowsy. I think he'll go straight to the bed. He had an exhaustive seminar yesterday also, and today
also. Today also. But actually we require a lot of background work to make them reality. So that, takes our toll.
Ever Man Friday, Dr. Ravi Chauhan for all the work which he does.
Everything, yes. He is the, backbone.
Shamshul Huda, Dr. Ashok Sham.
And Shamshul Huda is also backbone. Both of them, these young boys, they,
double spine. They have a double spine.
Thank you.
Yeah.
And all the delegates who must have been staying awake with us till now and participating there. Thank you and all the best.
Thank you.
Thank
sir.
you, everyone. Bye. Good night, and all the audience who bear with us. Thank you.
Dr.
Shamsul,
Shamsul,
make it
stop the
offline.
live stream.
Shall I stop live stream, sir?
Yeah.